NHS Financial Trust meeting, the board meeting. That's now, Joanna, you were talking to people just now, so please introduce yourself.
So my name is Joanna Watson. I'm a senior consultant from the Good Governance Institute, and I'm the lead consultant for the well-led review that we're carrying out. This is actually our first part of the field work. The contractual licenses are all being signed off. So this is the just being signed off now. So this is the first thing we're doing is observing the board today. My colleague Normie will be joining at some point as well, so to observe. And then over the next few weeks, we'll be interviewing, observing meetings, reading lots of documents, and looking forward to meeting you in person in October.
Well, you're very welcome. Thanks very
Thank
much
you.
indeed. So if we can just go to any apologies for absence, Sally?
Jo Stimpson has given her apologies.
Okay, thank you. Any conflicts of interest, colleagues? I can see no hands raised. If we go to the minutes of the last meeting for any observations that people have got on that, any matters arising that haven't already been raised, page 1, page 2, page 3, 4, 5, and 6. So let's just even in. If there's nothing from there, then we'll move on to the next item. Any matters arising from that from colleagues that's not already in the agenda? And they'll move on to the board assurance framework. Is there anything to raise on that, Sally, that we're not going to talk about within the agenda?
I think it's all covered, actually, yeah.
Okay, all right, thank you. And if you remind me, at our next formal board, we're going through the BAF in full, aren't we, at that time?
That's our 6-monthly full review, yeah.
Okay, all right, thanks very much. Now, item 5, which was listening to our service users and carers, we had quite a good discussion amongst colleague Neds just now on that, and some real positives about the steps we're taking to listen to service users and carers. And is that Neil going to present on this?
Thanks, Andy. Really happy to present. Just to give some context, of course, it's really important that all of us are aware of the experience of our service users. This is how we discover what's actually happening in our services. This is how we can find out things that we don't know about just by listening to people. And obviously, we have many services. So over the last year, we've been developing our involved infrastructure. Our involved infrastructure is there to help everyone integrate lived experience into their daily work, either through quality improvement or day-to-day working, be that with lived experience practitioners or volunteers. So it's both co-production and co-design, it's both. Some good news, just last month, we managed to get fully staffed. So we have all our public and patient participation leads enroll. We have our carer and support network lead enroll. And actually, we're now consulting widely so that we can develop our strategy for December. Because it's an infrastructure, that means it's integrated across the trust. Infrastructures are funny in that way because it's quite hard to sort of pinpoint where they are. But the point is we want it to be a supportive structure that will help all of our staff integrate and use lived experience outside of just meeting people in a treatment setting. So working more collaboratively. As part of our strategy, one of the things we want to do is to provide assurance to the board that co-production is happening. So we're doing a mapping exercise where we're mapping not only the quantity where co-production is happening, but nowadays you really have to look at what the quality of the co-production is. You need to understand whether it's a kind of very simple form or whether it's a form where you're genuinely working together with our service users to kind of create positive service development. That means things like bringing people in from the start of projects and helping people, adjusting meetings so that they're more user-friendly. So we've got a method to kind of map both of those areas. We've been talking quite a lot about how to bring stories to the board. how to bring lived experience. And some boards do that. They bring lived experience stories. One of the things I would say about that is it is always useful to hear what people have experienced, but you always have the challenge of that, is that representative of what's happening across the board? So one of the things we learned, and I think it's really strong in reports like the Ockenden report, is what's most important is that you do collect information, but you triangulate it always between a range of different experiences. So patient experience, QI projects, but complaints, serious incidents, and try and look for the trends, because that report was very helpful in pointing out that often we take these things in isolation, and actually you really get the good intelligence to the board when you triangulate. The other thing that I think we need to keep considering about how the board can be cited on the lived experience of our service users and carers is to just think about how much of a strain it is for service users to come to this meeting. I've had that experience. I came with four service users about 3 years ago. 3 of them declined on the day because it was just too exposing. It just felt really worrisome. So the idea of bringing films or other methods is something we should certainly consider. But the papers before you today, I think, are interesting because this is to do with board members going out and visiting the various areas of co-production that are happening. So you see a range of different groups, both carers groups, ResearchNet groups, different sort of areas where we can have these experiences. And it would be lovely to hear from the colleagues who went out just what they found when they have those conversations that don't necessarily have a tight agenda, where you can just openly ask, what are you experiencing? Because that's how we're going to find out what we don't know. So, so we have a range of reports, and this is an experiment for us to work out how we get sort of frontline intelligence up to the board. And I wonder, Andy, whether it's now helpful to kind of go to colleagues to see what they found, and perhaps for us to try and understand whether we're getting it right or what else we might need to do.
Yeah, thanks, Neil. I think your point around intelligence is a really good one, because we often find that something does go wrong. We knew about it, but in different pockets.
Yeah.
And it could have been complaints, it could have been sickness level, it could have been a range of different things that sit in different silos within the organisation. And how we pull that together, often focused on a location or an individual, that when we do amalgamate it, it's a lot of stuff that perhaps we should have known about. Firstly, I say really well done. This is a really good beginning. I do endorse your point around some of the patient stories. I've sat in on other boards, and I think, well, what is it we're going to do as a result of this? Or is it just something that is on the agenda that makes people think, well, we've heard from you, thank you very much, we're now going to move on. And one of the issues for me about is how we take this forward is who grabs the actions, who does something with it, and how do we feed that back? So it's not just a visit, it's a visit with a purpose. And the other thing we were talking about just beforehand was perhaps involving governors rather more in the visits with the NEDs. I'm loath to involve the exec up to their ears in work, but it's how we can make more use of other colleagues to hear from service users and carers, and how we feed that back. Anyway, on that point, now colleagues have put in their reports. We've got a very full agenda today, so it's really just highlighting any issues that you may have had from your visits. And just looking down my papers, Yemisi, you had a visit to LXP support development meeting.
I did. Thanks, Andy. Obviously the details of the visit are in the report, and it was really a positive visit that I had, and what I wanted to say was they had a lot of enthusiasm and drive and passion, and that as a board that we just need to harness that and continue to develop it, because they're a great bunch of people. They do the value add that they have for our services is brilliant, and we do really need to encourage that and develop them. And it's amazing where we can go with this. And it's great that, again, we're thinking outside the box of how we can offer a holistic offer to our service users. Thanks.
Thank you, Yemisi. Sophie, please.
Yes, as with Yemisi, I put everything in the paper. It was a really interesting visit, and I would just like to highlight I had a very good pre-meet with Jacqueline, and that now Janice has been appointed carer lead. That will hopefully have a real impact on the issues that were raised at that meeting. But what did really resonate with me was the fact that the group felt that they had been able to raise these issues. They did have the visibility of board members and exec visits, but what was happening as a result? That was the repeated question. So the work that you're doing, Neil, I'm sure is going to help answer that, and completely take the point as well that we need to triangulate this. I heard from people who had their stories, but that needs to be looked at in a wider context and not seen as, well, we've been to the group, we've heard them, now let's move on. So just really reassuring to know that this is ongoing and it's going to be integral to how we look at this, and to just highlight as well the role of carers. So it's patient and carer involvement that's really, really important. That's what the group wanted me to tell the board, and so that's what I put in my paper, and that's what I'm saying now. Thanks.
I thought that was a very powerful point, and there's one of the reasons I wanted to hear from these reports, that there is that issue, but what's going to happen as a result of this? I'm told now we've got member of staff going to capture this and hopefully feedback in the way that we do with our board visits at some stage, sometime in the future. Stephen, please.
Yeah, thanks, Andy, and thanks Neil for setting up the meeting with Bromley Research Net. I have to say it was a very positive meeting, and actually interesting what Neil was saying about some of the service users pulling out of meetings at the last minute, not through lack of confidence, because in fact certainly the group we saw articulated their points really well, and I'm sure Neil would agree that several of them I think would be very good at a board meeting. Actually, learnings for me was first of all the benefit to themselves as a group from just meeting, even if nothing else happened, as self-supporting. The improvements that they've made, and they gave good examples of Betts Ward and London Ambulance Service, a card that was prepared for use by paramedics. So I think, it'd be very good for us to hear a lot more about those improvements at board level. Also, I think they were saying about, in terms of dealing with our own staff, their experience was rather mixed. They felt some staff were very good to work with, and some perhaps a little bit more resistant. But what was interesting as well, they were very empathetic about the pressures our staff were under. So this wasn't just sort of open criticism of what we were doing or what our staff reaction. They were really appreciating that due to COVID and vacancies, our staff were under enormous pressures. And I think, as Sophie's touched on, they feel we do need to get a little bit better at communicating the outcomes of the suggestions that they'd made. It was a good visit. I've got other visits to come, and some useful learnings coming out of it, of how we can do things a bit better and publicise a little bit better the successful work done by the service users in providing suggestions.
Thanks, Stephen. Suzanne, please.
A couple of brief points. I just wanted to suggest that we make sure that the visits that are being organised under this programme probably also link in with other visits which are happening in other programmes. And I'm thinking particularly the Improving Lives visits, because all of those visits do involve us talking with our service users and carers. So in a way, if those kill two birds with one stone, we don't want to be repeating the work. And in that light is to remember the really important conversations that we have with our service users, clients in prisons. So some of the most important conversations I've had in the Improving Lives reviews of prisons have been with the prisoners there. And because these things are a bit difficult to organise, it's why I'm suggesting that perhaps we think quite carefully about how something being done for one purpose can also fulfil the purpose of ensuring that conversation that's had with the service users in that context is something that we can be thinking about at the board.
Thanks, Suzanne. Neil, please.
Those are great points. Those are great points. I wonder if I could take the point about following through on actions so that we're not just listening and noting and doing nothing. And I wonder if I could use Sophie's example from the carers group, because they are often a group which experience a lot of marginalization just in the process of care, you know, that in the busy world, their voice is not always taken into account. There's certain complexity with bringing it into that process. So we have a support network and carers strategy that was developed with carers groups. That was developed with, I think, some really original ideas that we want to continue to sort of pursue. One of the things we thought very carefully about when bringing in a carers lead, this is going to be obvious, was that, of course, the carers lead is not going to do all of this. Her role is actually to help directorates, service clinical directorates, to begin to action the strategy that we already have. And key to that is going to be the patient experience leads. So in respect to that, we measure who's in an individual's support network, and that includes carers. And carers were very happy that we took that approach. We've been doing very well on the measures, but measuring who and establishing who's in the carer support network is not enough. We need to be engaging with them. And what carers told us was that actually teams can be very intimidating to engage with, going into buildings, knowing what everyone's role is. So our next point in the strategy, which we're working through PQAC, so working through patient experience through to PQAC, is to start to bring information. So the carers lead will start to collect information on what teams are doing to make teams more accessible to carers. So that's like welcome packs, welcome videos, welcome groups. And we have some really good pockets of brilliant examples. We need those to spread. So we're no longer just staying with measuring who's in the support network. We need to do the next step, which is how they're welcomed into the team and how the co-production happens there. And after that, we have a series of steps. That step was given to us by carers. We didn't know how intimidating our services were until they told us that actually what is the difference between a psychologist and a psychiatrist, and things which are just bread and butter to us. So we have a method for capturing those actions, and the patient experience group is part of that. And that will, of course, feed through PQAC and come to the board. But you're absolutely right. It needs to not just be listening. It needs to be understanding through triangulation, and then the actions kind of smart from that point on.
Thanks, Neil. I mean, I think this is really, really good discussion, and I'm very grateful for bringing this forward. I think it's a real development for us. I was thinking about the issues arising there, capturing the various visits that Suzanne was talking about, how we do that without making it too bureaucratic, perhaps looking again at the board visits, and maybe just another item on that sheet, perhaps, Sally, you know, to sort of capture something there about talking to patients, talking to service users, depending upon what that visit might be, and how we bring that together under your wing, Neil. And then the most important bit, as we've all said all throughout this, is what are we going to do about it? How does this feedback? So we're not just gathering stuff, we're actually going to do something about it. That'll need, obviously, quite a lot of management, because we found in the past that, you know, you can end up with dozens and dozens of recommendations, almost overwhelm people. I think it's synthesizing it down into things we can actually do. And then back to Sophie's visit, to make sure the next time we go to that we can actually say, well, something has changed as a result of that visit. Otherwise, to be frank, they become rather less than helpful to go and do that again. But great stuff, Neil. Really pleased. Look forward to this, I think, being on every agenda. And I think our mind as a board is very open to any approach to this, whether it be video beforehand, you know, whatever approach we might do to emphasize the importance of those that we look after and their carers as well. Anyway, anything else on that point? If not, thanks ever so much. We'll just go on to a brief update from myself. August has been a really interesting time to get out and about, because there's a lull sometimes, isn't there, between meetings. And you know, I met with David Sloman, the National Coup, also with Andrew Ridley, the director for London, had a really interesting discussion on mental health trusts with him and his less than positive experience of a few other Trust. Oxleas was not in the frame, but very, very interested in how crisis lines actually work. What happens when you ring it. Very interested in the impact of mental health cars, and it's good to see that that is being expanded, and very interested about how we can, the issues around mental health patients within ED, and no doubt we'll be touching on that today. I did have a meeting with the last Secretary of State for Health, but that's over now, isn't it? So we look forward to hearing from our new Secretary of State. Out about visiting our community mental health teams, which if we know the CQC are visiting, I think next week. Clearly, as with all of our teams, all of our community teams, considerable pressure. And the thing I found from those various visits was the issues of demand, the complexity of demand, and staff vacancies. Those were the themes that cropped up time and time again, whichever unit I was going to visit. In my 6 years as chair, I don't think I've quite seen such a degree of pressure on our services than ever before. And that manifested itself in all sorts of ways, added to the real concerns that people have over the cost of living, the cost of fuel, right back to the hardy perennials around parking, access to vehicles, all of those things that constantly crop up. And also real issues about how we refer back to primary care and the challenge of getting our waiting list down by actually moving people back to other services as well, that cropped up quite a lot. Really good visit by the new leader of Royal Borough of Greenwich, who came to visit us and went to Oxleas House and the mental health assessment area. I thought, Iffy, that was a really productive meeting. He was very, very interested in the services that we offered. And a good visit to the Bracton to talk to our various patients there. And again, very positive feedback actually from what was happening with all of the extra activities. And that's one thing I think is really impressive when you go to the Bracton, to see all of the activities that we put on there. And I think this week, great start to the week was the opening of the Source, or the reopening, I should say, of the Source over in Horn Park. For those who don't remember the Source, it was just a shop front with a few members of staff, and you could just about get anything done there you wanted, from advice, getting your stitches out. It was a wonderful service to a part of our community that feels rather left behind in all sorts of ways. And it was a real shame when that service shut through the commissioners, but wonderful to see it reopen. And a wonderful email today or yesterday from the RBG thanking the Oxleas staff for their energy and effort for getting this off the ground. Talk about a can-do attitude, nothing too much trouble, and it really drove it along with our partners from community, the Van Charlton Community Trust as well. So that was a real great thing, to be opening a service rather than shutting one. And the turnout from the community and from many others was really, really superb. So that was sort of a real good news week. So the themes running out from all my visits has been those issues around pressure. And clearly that's not going to change. We've got all of the issues, societal issues that are coming at us from the rise in energy costs, which are going to impact on our staff, impact on our patients, impact upon the demands upon our service, which I think are going to be considerable, and they're going to play into a whole range of things that we do. Listening to our new Secretary of State, actually we welcome her to her new and very demanding role. And she was talking about her ABCD, for those who talk about ambulance response times, and that's very much around delays within ED. And I've done a number of visits to ED of late, including the QEH and the PRU, and visiting our old CEO, Matthew Trainer, over at Queen's Romford. And that is an interesting experience if you ever want to go and visit that ED. Clearly, a lot of elderly frail, bed after bed after bed, elderly frail, which takes us back to community issues. Jane, your comment the other day when we were chatting about the pressure on our community staff in there. It's not just about rushing another ambulance to ED. It's what actually happens when you get to ED. How can we stop people getting in, and how they can get people moving through? And that takes us right back to social care. She's also talking about B for backlogs, and that will be a whole range of backlogs. I think particularly probably talking about elective care. But we've all got our backlogs, and we only got to look at our own CAMS waiting times to see that. And her C for care, which is obviously social care, and whether or not investment in that, and maybe diversion of NHS funds into social care to free up space there, and that's, you know, that's an interesting one. And then her D, which is for other doctors and dentists, and the pressures on all of our staff, but particularly about recruitment of doctors and dentists. And we find that ourselves. When I chair the panel, the recruitment quite often, you know, it's not, we don't get that many applications. But anyway, as I say, we welcome her into her post, and you know, she's setting out that agenda, which I think is one that is fairly obvious, to be frank. But I'm just thinking about how all these things are going to play into our world and how we react to that in a very, very challenging time, when I'm conscious of that huge pressure on our staff, but also a huge pressure on all our leaders across the organisation. And having seen them working so hard in very, very challenging times, all I can say is I'm enormously impressed with our team. And thank you very much for all the energy and efforts that you put in to take us through. I was going to stop using the term unprecedented because I said it through in COVID, but this is unprecedented. I don't think anyone has seen anything like what we might be facing as we come through. Anyone got any questions for me on my update? If not, we'll go straight on to Iffy, please. Thank you.
Thank you, Chair. Very comprehensive update there. Thanks for that. So I'm going to assume that my report has been read by board members, and I'll therefore just highlight a few things, but I'll be more than happy to take questions. So firstly, there's no doubt that board members remember our many discussions about patient safety and, you know, the real challenge about how we demonstrate learning from incidents or complaints and things like that. And so 3 weeks ago, NHS England published a new approach to responding to safety incidents, the Patient Safety Incident Response Framework, or PSIRF for short, which we now have to adopt across the NHS. I have appended to my paper links that you can access to read more about it. But what is very clear is that not only does it replace the serious incident framework, which we've had for over a decade, which was quite prescriptive and seems to point us to look at specific types of incidents. This one requires us to learn from all types of patient safety incidents. The board is, of course, required to appoint an executive lead for this, and I propose that Jane Wells be appointed the executive lead. Jane, of course, is our director of nursing, but she has led patient safety agenda for so many years, and she and her team, even ahead of this publication, have been thinking about how to adopt it. And I know for a fact that we've had a number of meetings, a number of NHS early adopters, and Jane and a few others in her team have already started attending courses and programs to help us hit the ground running. But I have to emphasize, though, that although Jane is going to be the executive lead, this is the responsibility of the entire executive, because this will require not just energy, time, and focus, but it's going to be somewhat transformational in terms of cultural change that we need. How do we move our approach to incidents by emphasizing systems, something that Suzanne and colleagues on the board have been helping us think about for years, and also ensure that through that systems working and discussions that learning calls. And so that's the main ask from my paper of the board, that the board agrees to the nomination of Jim as the lead. A number of other things that I kind of want to touch on, and I know that Andy touched briefly on energy costs and the fact that this is going to not just affect our users of services, but also our staff. I want to mention the pay award, which will be backdated to April, but which many of the unions that represent our staff groups have described as being disappointing, and quite a number of them have called for ballots to consider strike action. Only a few days ago, I received one such letter from the LCN, and they point to high inflation, cost of living, well costs, etc. And many would argue this, in fact, doesn't do anything at all to people's paychecks. And something I was reading the other day is that for some senior members of staff, they will actually receive less money on account of the fact that their pension contributions rise. So the concern, of course, is that if we get into a situation where there are lots of balloting and get into a situation where we have strikes, that's going to really disrupt NHS services. I wouldn't mention the agency expenditure because we have that coming later. But I just want to mention briefly the real challenge that many trusts, particularly our neighboring trust, GSTT, for example, who had a complete collapse of their IT systems back in July, and SLAM, and I think about 10 or more other mental and community health trusts who also had a complete collapse of their systems. Abby and I were on a call yesterday morning just discussing the second incident that affected mental health and community providers, including SLAM. And the impact was near catastrophic. For example, patients who were on the ward, suddenly they didn't have any access to their risk history, their detention history, their medication, information about allergies, etc. And so there was a real concern about how we mitigate this, and I'm sure that we'll talk about this when we discuss the infrastructure committee. The other worrying thing, of course, is that both GSTT and SLAM and other trusts expect that it will take them several months to recapture the data that they've lost, and in fact, they're still suffering the impact of this. So Andy has mentioned that we have the CQC. They're coming to us from tomorrow for a week to inspect our community mental health teams. There are 10 teams in total, and we've been given final feedback date of the 20th of September to attend to hear the outcome of that inspection. Although, as they often do, they will meet with us at the end of each day to draw attention to any concerns that they have. Two more things. I want to just formally thank our staff networks, Wellbeing Champions, for a successful Trust Wellbeing Week. And also my thanks goes to our volunteers, shadow executive, for all they do to help us deliver high quality care to users of our services and indeed the wider community. And then finally, some of our ladies who are here up in Birmingham, because our Building the Fairer Oxleas work has been shortlisted for Excellence in People Awards that the winners will be announced later on tonight. So let's keep our fingers crossed that Oxleas be awarded something. On that note, I'll end and just take questions. Thank you.
Thank you very much, Ife. Stephen, please.
Thanks, Andy, and thanks, Ife. And delighted on the patient safety framework that Jane is going to be overseeing that, which would be great. And just sticking with that and looking later on in the bundle, page 243, where we've got the comments from NHS providers, where they mention about the 132,000 vacancies in the NHS, and particularly to make this framework work successfully, about a need to bolster the workforce, which obviously ties in with that last figure, so that's difficult, but finding adequate time for training because of that issue. So that's what I just wanted to just explore your thoughts on, because obviously the way the new framework is set up, which is good in terms of being more transparent and open and focusing on learning, but that in itself will mean time being set aside for training. So just what are your thoughts on how we're going to ensure that that happens, given that a lot of staff, I think, will be saying we're already short of staff, we haven't got time for this training, basically.
So, of course, part of what Jane will lead us with is setting out the plan in terms of how we adopt and deliver this. And my thoughts initially are that the training has got to be certainly for our team, for those who are going to be involved in investigations, because we're going to have to move away from the root cause analysis approach and begin to think more broadly about what we can do to make a difference. I think that the training for our staff, we haven't quite formulated how we do that and whether it's going to be a combination of ways via general giveaway to come in, which may include e-learning or face-to-face team discussions, etc. But we really need to think along those lines. It's got to be something that would take to them in a variety of ways, because we cannot, as we used to 3 or 4 years ago, bring people into one place, etc. And part of that training, I think, will be about understanding the new approach, but also helping them understand what we will be expecting in any patient safety discussions that we have in terms of trying to get at those systems issues that will really enable us to change and drive learning and improvement. Jen, do you want to come in?
Yes, I think that's an excellent question, and it is laid out quite well within the PSERF documentation. We've already started the training. We introduced the patient safety syllabus for all staff last year, which is available on the Learning Fish, and we will start monitoring that soon. That's a really quick sort of half-hour training for people to do. And the Serious Incident team and myself have all done the HSIB training, which is 10 weeks, about 30 hours. So we've been putting that into practice. But within all of the documentation around the patient safety incident response framework, there is really clear guidance about who needs to do what level. So not everybody will need to do everything. And there is a national procurement framework where training providers have been identified as well, so that we can access that. I've set up an implementation group which will kick off soon, and as part of that we will have under the sort of standards for competence and capacity, we will develop a training plan and look at the procurement. We'll also be looking at the policy planning and oversight and the engagement and involvement of those affected. And that will also include bringing on board our patient safety partners, as well as developing proportionate responses. So in terms of the training, there's a whole work stream that we need to do about engagement and awareness raising about the cultural and transformational behavioural shift away from looking at serious incidents to actually learning from all patient safety events, to one where we've got a cohort of staff who've got the expertise as being learning practitioners who have got the skills in different methodologies, such as the system engineering initiatives for patient safety, lots of systems and human factors experiences. So we will make sure that we do that training needs analysis early on, and we'll establish who needs what training. I think there is recognition that this is a transition. While we are required to transition to the PSERF over 12 months, it's really clear in all of the documentation and the communication that this is still going to be a journey for everybody, and we will all be learning together. We will kick off as ICSs, but this is a national initiative. And if anyone does get the opportunity, the very first webinar on PSERF was held on Monday. It's an hour and a half, and the recording is on the NHS Future platforms. And it's presented by the 3 people who've been absolutely instrumental throughout the design, the implementation and the pilot phases. If anybody would like the link, I can share it, but it's an absolutely brilliant watch, and it demystifies PSERF really, really well.
Thanks very much, Jane. Rachel, please.
Yeah, briefly, I think it's a really important point, Steve, about kind of what we expect of people in terms of training, given how busy people are and what we've just already been hearing about the staffing pressures. And I think something that Oxleas does well, actually, is a recognition that layering training and mandatory training on top of mandatory training just to make ourselves feel better, even though that doesn't necessarily improve outcomes, is something that we reject. So we are really careful about what we require people to do in terms of training. What I think that means is that then when there is something like this that really needs focus, we've got the space, because we haven't just got a list of 67 things that we expect everybody to do. So it is something we're very alive to, that balance between pressures on people's work, but also making sure that we deliver training that really adds value.
Yeah, that's a very good point, Rachel. Suzanne, please.
A couple of points, and just to pick up what Jane has said about the transition. I think that it may take a year to transition some of our systems to PSURF, but I think that we need to look at this as being a 5-year commitment to cultural change. It's going to take a lot to move the tanker away from what many people would recognise as been a blame culture, sort of focused on identifying root causes, to thinking about things in a different way. And so I think it is a long-term challenge, and we should tackle it on that basis. The second point I just wanted to make is in relation to what we mean by learning. It's probably one of the most degraded terms in the NHS. We talk about learning from events, and they keep on happening because we're not very good learners in a way. I think that the learning is not just about providing training to staff. We need to really think differently about how we make our services safe, in the sense of preventing staff from making mistakes which are caused by systems. So this is not just about teaching staff more about patient safety, although something of that will be involved. We need to think really seriously about how far do our systems as an organisation support safe care, and that's really what I mean about the shift. I think that this is going to hopefully procure. So some of the things that we currently do, like automatically changing policies as part of an action plan, we need to stop doing a load of the old stuff that we've done in the past, which we know doesn't work, and start thinking much more carefully about how do we do things that do work. So that's what the real learning is going to be in.
I think it's a really good point, that, Suzanne, because we've seen in the past, haven't we, that lots of recommendations from SIs, some of which duplicate or partially duplicate previous ones, and end up stacking up lots of things, and some of which are actually impractical. And I think it's being really careful about honing in on those, and what are we actually going to do that everyone agrees to, that is real when it hits the ground. Because so often we find policies that we bring in don't actually work when you do hit the ground on these things. So, very good point. I'll get that on this. Yemisi.
Thanks, Andy. Oh, I'm getting. Okay, I'm still getting some feedback, unfortunately. Is that improved? Okay, excellent, superb. I just wanted to briefly ask a question about the Winter Pressures Action Plan and what we are specifically doing to it. So, about it. So we talk about the joint response cars, the Resplendent programme, helping ambulances in A&E to reduce A&E pressure, the crisis line. Although many of those I recognise already, so I just wanted to ask how have we modified those in relation to the letter that's come from NHSE, or it's just a case of we had these already in place and this should allow us to achieve the actions? I just wanted a bit more detail on that. Thank you.
Thank you, Yemisi. I think it's fair to say that many of these are actions that were already in train, and that was certainly the way that this was received. What we've now been asked to do is to submit what we are actually going to do in terms of with the modeling, increasing bed numbers, etc. So for us, for example, I suppose the only thing that we haven't actually achieved is the creation of more virtual beds, in the community, and what that would mean, and what's the role for social care in doing that. So the bulk of it we do already. We're doing that with our partners because it's across the system, and there are some aspects that are relatively new, not necessarily because they've come out of this ask, but because those were things that were already we were already beginning to think about, that we now need to submit our proposals and our plans for. And as with most of these things, some money is attached to it, and the degree to which we're able to succeed at them will depend, as we all know, on finding the staff, and so that, I think, it's going to be the rate limiting step.
Okay, Yemisi? Jim, please.
Thanks, Andy. Just following on from Yemisi's questions, and my question was on the same topic. I can see this coming from NHS England, and from my point of view, it seems quite light touch, given the pressures that we're going to be under this winter. Sort of more NHS #1 call handlers. I mean, okay, more people answer the phone, but the ambulances are still going to wait at ED to discharge patients because there aren't in beds there. So is there anything else outside of this that Oxleas is planning to do for this winter? Because for all, I mean, from all the reports, this winter's going to be quite extreme if it's a hard winter.
Yes. So there are a number of things. You will know that at the board, we had agreed that we're going to open up more beds. We think that should happen in November, and I'm sure we'll touch on that in the course of this board meeting. I've talked about the fact that we need to be part of the discussions about virtual beds, and how we do that with the local authority. And of course, one of the things that we do with Greenwich and Lewisham and Greenwich Trust in particular is how we support them with our rapid response teams in the community so that people don't reach up in ED, and how we support them even when people are in ED in terms of taking people back into the community, about Home First, for example. And then there's the other aspect of how do we then support people to be discharged home early, So these are things that I think one of the ways that I view this, at least, is that there isn't anything new. It's about stepping up a gear or two to make sure that we do more of these things. And also that we have regular meetings to unblock where there are blocks. And that's the kind of meeting that Ian and I go to. Certainly I get drawn into it on a weekly basis, but there are other people who have daily meetings, as I'm sure you know, just thinking about where the blocks are and then escalating to Ian or myself to make sure that we support and unblock those things.
Thanks. Thanks, Iffy. Just a quick question, follow up then. I presume with the new ICS structure, that can happen more, we can integrate better with the acutes and we can do more in terms of supporting them than them supporting us. So will those conversations go on within the ICS, I presume, structure?
Yes, those conversations go on within the ICS. So the urgent and emergency care group that is co-chaired by Sarah and Ben, Chief Exec of the Lewisham and Greenwich Trust, they ultimately feed back to the ICB, but they then would have regular meetings with 4 or 5 systems, the Lewisham group, our group, Bexley and Greenwich, there's a Bromley group, and then the Lambeth and Southwark group. That's the way it's divided in terms of the systems, where each will then say what they're doing, judged, of course, by set parameters such as ambulance delays, etc. And then we would, at the ICS, be looking at how we are doing in Southeast London. So the ICS coordinates it, but the groups that coordinate the ICS will continue to work more locally, because of course this has got to be addressed more locally, as you know.
Yeah, thanks, Iffy. Yemisi, please.
I just wanted to pick up on another point in the report, and it was about Eltham Community. Obviously, it says that we are doing consultation with our staff due to the move, but I just wanted to ask if there are any other impacts on us, because I was thinking more maybe a reputational impacts of how Greenwich patients would feel now having to go to to the hospital, and whether we were thinking of consulting with them, or we think there's sufficient consultation that's happening from an ICS level that should answer those questions for us. I was just thinking there could be more of an impact than just a workforce issue. Thanks.
Yes, so I suppose there are 2 aspects to this. So the bits you've talked about in terms of users of services and local residents, that's been addressed from a wider system point of view. It's not primarily an Oxleas issue, and there's been a lot of that going on. There is still some of that going on, including discussions, and Ian may want to comment, in meetings with local MPs and local elected officials just to make sure that everyone understands, agrees, and that any questions are addressed. And what we are then doing is, given that all of that wider consultation has been ongoing for a little while, what we're then doing is doing our bit, which is about our staff who are employed to work on that. So there are those two things that have been going on for some time.
Thank you. Ian, please.
Yeah, thanks, Andy. I mean, just to say, Yemisi, that ahead of launching the staff consultation, there was a lot of engagement with us, if he says, with local MPs, the portfolio holder for Royal Borough of Greenwich for health, and local councillors, which was led by me and by Neil Kennett Brown, who is the coup for Greenwich. So we did a lot of work with them to help them to understand what we were looking to achieve with the changes to our intermediate care bed base, but also, as if he says, framing this as a kind of wider conversation around the future of Eltham Community Hospital. We're following that up with an appearance at the Scrutiny Committee in Greenwich in a couple of weeks. Again, Neil and I will co-present that. And as we speak this week, there is a series of public consultation meetings which we are participating in. We are part of the ICS. I think we're trying to very much live what this new world is about, which is the ICS includes Oxleas, and everything we do is in partnership. So we're using that as an opportunity to talk to local people about what the vision is for the hospital, but also it is an opportunity to talk through some of the practical issues which will inevitably come about from locating those beds on one site. But I have to say it's been a pretty successful process so far, both internally and externally.
Andy, may I just add a couple of things, if I may? So, of course, you and I, Andy, were involved in a meeting with the local MP quite a few months ago over this. This has been going on for a while. And I'm not sure if this is, I don't think this is publicly known, but Eltham Community Hospital, as you see in that paper, there's a suggestion that it will become one of the community diagnostic centres. Only yesterday we heard that the national team have approved it as such, and all that we're waiting for now is approval from the ICB.
I think that's good news. I mean, Eltham is a great facility, but we all know it's been underused for some considerable time, and the consolidation at Meadowview, I think, makes sense. And it's great to see something that's going to stay open and provide a really good service to the local community. So I think these are some real pluses on that. And I think the the consultation with others has been very, very positive, and I think that's helped everyone to understand where we're at on this particular issue. There's one matter there. Do we have to appoint Jane, do we not, as our executive lead for a patient safety incident response framework, which I think is unanimous as far as I can see from colleagues on the screen. So well done, Jane. Thanks very much for that. Okay, if there's nothing else for Iffy, we will move on to Ian, please.
Apologies, Andy, I'm struggling to get off mute. Morning, everyone. First of all, I just wanted to express my gratitude to Lorraine for putting together the report for today. I've just come back off 2 weeks leave, so bad planning on my part going straight into a board meeting, but I will do my best. I just wanted to kind of start off by echoing, I think, what Andy and Iffy has said. I think what remains as the overriding issue for across all our services is around demand and capacity. And I think, Andy, you're right to kind of stress the fact that I think wider concerns about cost of living are also playing on staff minds. So I think they are the big issues across all our services, no matter which ones you visit. There's a lot in the report. I wanted to just highlight that there are some, around that theme of demand and capacity, I think there's quite a lot of detail in there around what individual services are doing. I think there's a really positive position being reported by our adult community physical health services on the work that they're doing to reduce weights, which is fantastic, given what we know about demand. But there remain real challenges in particular service lines. And I wanted to just highlight CAMS, and in particular the situation in Bromley CAMS. So Bromley CAMS in particular has been in a state of business continuity now for some time. They are in the process of emerging from that, and there is a lot of work that sits under this report that they are doing around both reducing vacancies, but also working internally, but with the wider system, wider partners at place to look at how we manage referrals. But I think it's true to say that the challenges are still quite significant. Vacancies and weights remain as issues on the Directorate Risk Register. What I wanted to suggest to the board, if this would be okay, would be to bring a more detailed report back to PQAC, just to talk about in a bit more detail about what CAMS are doing, and to try and reassure colleagues of the work that is happening. Like I say, talking to the Directorate, they feel that they are emerging from the difficult situation, but there is still some way to go. So I just thought it would be helpful to highlight that. The other things I was just going to mention, ECA, the Eltham Community Health Consultation, we've already covered. I wanted to just highlight that after a long time, we are next month going to be able to open up hydrotherapy for adult learning disability users, which is fantastic, and has been a really difficult situation to navigate through the kind of clinical need for people to have access to hydrotherapy with the IPC guidance. But I think we're now in a position to be able to reopen that for treatment. And in addition, as it says in the report, in Greenwich, we actually now have extra hydrotherapy available for the wider community, which will help for kind of non-treatment based interventions such as relaxation and swimming for people who need their water at a higher temperature, which is a lot of our kind of more physically disabled service users. And then the last thing I was just going to highlight was, and we will come back to this, I think, later on the agenda, is that the work to mobilise services in South West England prisons has now commenced with a series of meetings. And both, I'm pleased to say that both Jim and Suzanne have joined me in the meetings, the beginning of the meetings, start of the meetings with commissioners in South West England. And I'm very happy to take questions.
Thanks very much, Ian. I think great news on the hydrotherapy pool. I think everyone was really looking forward to that coming back. I noticed, I don't want to get too much detail, but pool car is mentioned. That crops up quite a bit. Be interested to hear whether or not it's going to get expanded. The new ward, timings around that. Older adult mental health ward occupancy level, because that does seem to be quite a few times, and any delays on ligature points on the others.
Yep, happy to take those, Andy. You might need to remind me as I go along. In terms of the mental health opening of a ward, we're on course to open this in November. I need to catch up with Aisling now I'm back from leave on where we are with the workforce. That was always going to be the limiting factor, but my sense is that we're confident in opening up those beds in November. The question around older people's mental health, Abby might want to come in on this. So as the report says, we consistently report underuse of both our functional and dementia beds for older people's mental health, but actually turning that into a kind of an offer proves quite difficult from an estate's point of view. But I think Abby, you may want to come in on the fact that you have been talking with the Older People's Mental Health Clinical Reference Group about how we might start conceptualizing some of those beds in a different way, which would move us away from a strict age-orientated criteria, more around one that is linked to frailty. Abby, did you want to say anything more around that?
Yes, we're working on that, but over the last 2 weeks while you've been on leave, the beds have now started being used, so they don't have the level of vacancies. And I think we're going to have to look at what winter holds actually, but we are working on the criteria so that they can be much more flexible, because it's about the flexibility of being able to use their beds. But we've seen a trend over the last 2 or 3 weeks of an increase in use in the functional and dementia older adult beds actually. So we just need to keep an eye on that. I don't know whether we're going back to pre-COVID levels, and the people that are being admitted now are very unwell on those wards. So we'll just have to see, but we will get the criteria in place so that when we do need to use it, we can use it very quickly and very flexibly. Because I think part of the problem is the inflexibility that seems to have been built into the system, and that's what we're going to work on.
Thanks, Abby. In terms of your question about pool cars, Andy, I mean, I think the paper sets out how successful their introduction in home treatment has been. I mean, it's not the sole kind of success factor in the reset of HTT, but it's played a significant part. The plan is to look at an expansion of the pool car offer, and certainly within adult community physical health, there is work underway to look at introducing them there. But I think given what we know about the kind of cost of living crisis and the concern that people have around using their own cars, and then the delay that they inevitably face in getting those expenses back, I personally think that the pool car offer is something that we should probably get behind, and I think Rachel T. Evans is supportive of that approach. Was there anything else that I didn't cover?
It was just around ligature point progress.
Yes, so I think Aisling put in the report that we are slowly getting towards a point where the work on the adult wards at Woodlands is about to be completed. Beds will come back into circulation. So that the exact timing of that, I need to go back and check, but it will be between now and the opening of the new ward in November.
Very good, thanks ever so much. Suzanne, please.
Thank you, Chair. So first off, I really appreciate some of the detail that we get in this report, and particularly I think Aisling's stands out as being a really good insight into what's going on within her directorate. And just on that, I think that she deserves some congratulation for the amount of reset work and quality improvement and continuous improvement that's going on in that directorate. I don't know whether she's with us today at the meeting, but I really hope that that could be communicated to her, because I think it comes across very clearly that there's a lot of development going on there. Looking down to the rest of the report, I think it's quite interesting that what we see from prisons was rather a different tone in terms of what they think it would be useful for us to include in the report. And I wonder whether they might be encouraged in future to have a look at the way in which Aisling has described some of the challenges in her directorate, and also within that context, the report on community mental health, which again sort of gave quite a lot of information about service user experience and the nature of the services, which we don't really see quite so much of from prisons. The thing that I wanted to pick out, and I'm just going to touch on this now because it actually links to the discussion we'll have later on health inequalities. It's about the plans for CAMS, and I've just missed the place which I'd got marked out here. Yeah, the business case for the Bromley Cams development. I just want to pick up, and this, as I say, I'll pick this up in more detail under the discussion around health inequalities, is about our thinking around that, particularly in relation to the needs that young women have and young women from different communities, because there's an intersectionality issue I think that we need to focus on. But as I say, I'll come back to that later when we talk about health inequalities, which might be a better place to have the discussion.
Thanks, Suzanne. Stephen, please.
Thanks, Andy. Thanks, Ian, and indeed Lorraine, as you rightly say, for providing a very comprehensive report. Ian, good news about the hydrotherapy unit, although I think for board, we'll also note that in terms of where we've discussed before, the general redevelopment of Goldie Lee, that does have implications for that. But nevertheless, it's great to see it back in use. Page 47, there's a reference to Swaleside. I've got a couple of questions on that. It talks about a vacancy rate at one stage of 85%, which I've never seen that figure before. I don't know if we've had it before. But while we're on Swaleside, we haven't heard for some time about the emotional wellbeing program, which started off there and had fantastic success. You know, reduction of suicidal thoughts by 66% and self-harm 57%. But tied in with our prison expansion, if you could just update us on what happened to the emotional wellbeing program. Is it still running? Is it going to be running in the new prison areas? Because certainly from what I saw before, it was a fantastic success. And then the final thing is just on the digital future. And I know you've been away, but there was a very interesting article in the Times on the 1st of September, which talked about robots being more effective than people at dealing with children and getting them to give honest feedback. But I'm tying that in with a report from King's, which talked about the benefits of remote monitoring. And I wonder if you could, and there's 25 projects around the UK dealing with 300,000 patients. My question is, can you just remind us about what, if anything, we are doing on remote monitoring? So to make it easier for you, the questions there are 85% at Swaleside vacancies. I'd never seen that before, but I can see it's improving. What's happened to the emotional wellbeing program? And then anything you want to say on remote monitoring.
Thanks, Steve. Yeah, so taking Swaleside first, Iffy and I actually visited together with Nicole from Rachel's team just before I went on leave. And the challenges that they faced at Swaleside have been, huge. And I think it has really taken its toll on the team down there in terms of their kind of morale and energy. Having said that, we've got some really fantastic leaders down there, and the tide is turning in terms of the vacancy rate coming down, but we are not out of the woods. I think the situation we inherited from the previous provider of physical health services was quite significant. So we had some frank conversations, I think, with the staff group, which I found really refreshing, with the wider team, but also I think candidly with the leaders themselves, where the rest of the team wasn't present. So I derived quite a lot of reassurance from that. But there's no doubt that I think in terms of our existing prison estate, Swaleside is the one that I am most preoccupied about. And I think outside of healthcare, I think as a prison, Swaleside is struggling. Unfortunately, we didn't get to speak to the governor. We did speak to the associate governor on his last day. But there was a point in time earlier in the summer where they were actually going to close a wing there because their prison staff vacancy rate was so high. It meant that the prisoners themselves weren't able to leave their cells to kind of access a whole range of things, not just healthcare, but other things as well. That hasn't actually come about. but I think they are very much on the kind of HMIP kind of radar. Having said that, I think, you know, like I say, I think there's some really good work going on there, but I think relating that to what you were saying, Suzanne, I absolutely take on board your comments around what might be helpful to see in future versions of this report, and some of that detail from colleagues in the prison service will certainly kind of add in. In terms of the emotional well-being service, it is very much still running, and alongside that, the PIPE programme, which you may remember from visiting there yourself. Again, we had probably about an hour, I think, talking to both service users and the staff, and the wider prison. I think it's a fantastic piece of work, and one of the things I think that Iffy and I reflected on is that we need to continually to kind of raise its profile within the kind of organisation, because it goes back to this point, which I've certainly talked to Suzanne about, which is how do you promote this good work, which is behind. We need to find every kind of avenue available to us, I think, to promote the good work that is happening in prisons. It's by its very nature, it's obscured from the rest of the organisation, and as we grow it, we absolutely need to kind of raise its profile. So yeah, it's a good news story there. And I think the challenge is well made in terms of how we might spread the learning from there to other places as we continue to expand our portfolio. The last question, I think, was around remote monitoring. I think it's fair to say, Steve, that we've got some way to go. I think we are expanding our digital offer. So, for example, relating this back to the point I was making around CAMS earlier, we are, for example, piloting a rapid online assessment in CAMS, which we've piloted outside Bromley, but to great success, actually. It's been received very well by service users, but also it means that we can more efficiently move through assessment. So I think there is more we can do to kind of harness the technology in that way. And I think Alison may want to come in, but Iffy, did you want to come in first?
If it's okay, I kind of want to come in. So just to make 3 points, if I may, all related to your question, Steve. The first is we were at Thameside yesterday. Amanda Pritchard was due to visit, but of course, new Secretary of State, she couldn't, but her senior team were there. And we had exactly the same conversation, given the wonderful work that the multiple teams do on the side. And the Health and Justice National Team, along with NHSC senior officials who work with Amanda, much of what we talked about is how do we promote this? Because in society, if you start talking about good work in prisons, people kind of think, well, should you really be doing that? You know, and there's a lot of good work, you know, the PIPE that Ian referenced, and also the health and well-being, emotional well-being work that you asked about. And I'm really quite delighted that we see this in our respective prisons, you know, doing some really fantastic work. Part of what we were talking about yesterday was all the work on trauma that goes on inside, and how that really helps prisoners, not just for when they're in prison, but when they leave prison, and the support they get with their health care, and how through all of that we're addressing inequalities. The second thing is about the remote monitoring and digital monitoring. Ian has, of course, talked mostly to mental health, but I can tell you that as we speak, I think it's today, that the ICS have invited quite a number of us because we plan to procure some more home monitoring for patients at home. So in my paper, I talked about the virtual ward. We need to create 1,000 of these. So these are people who, in the absence of those virtual wards, will be in ED and in hospital. And to enable us to do that successfully, there needs to be some kind of remote monitoring. So there's quite a bit of that going on, and there's a real appetite for that. I can also say that there are people who are at home in communities, not just in Southeast London, but up and down the country, who have a number of digital monitoring tools. The AI is an interesting one because you shared that article with me. I couldn't for the life of me figure out why it is that children will respond better to AI than to humans, you and I. But I kind of wonder whether this has anything to do with how we seem now to give young people from the ages of 2 or even, I don't know, 18 months, either an iPhone or iPad, so they're perhaps more comfortable with those that they are with humans, and therefore AIs might, they may be able to respond better to robots and stuff. But I think that there's no doubt about the next 5 to 10 years that we're going to see quite a lot in terms of bringing in digital more into our practice, not least because if the algorithms are right, they are better at predicting, and they predict consistently, like you and I, who are fallible.
Thank you, Ife. Jim, please.
I think Alison wanted to reply to the digital thing, question by Steve. Maybe her first, and then I can come in after.
Okay, fine. Alison, please.
Yeah, thanks. I mean, I was going to raise most of the points that Ife raised around use of virtual wards in community. I mean, I think during the pandemic, we saw in the acute sector really good use of virtual wards using oximetry, the oximetry at home program to monitor patients, and that's kind of now extended more broadly across the community setting. And I know that community services have been trying a product called Docabo, which enables them to monitor patients at home, and that can be used for frailty, COPD, diabetes. I'm not quite sure which areas they're using it in currently, but there certainly is a big appetite across the ICS to take the learning from the pandemic and create many more virtual wards across South East London.
Yeah, very promising. Thank you very much, Alison. Jim, please.
Question to Ian. So I'll just echo Suzanne's comments about the report, Ian. Thank you for the detailed report. And also really good news to see that the reset projects within acute and crisis mental health are starting to bear fruit. We can see some benefits. Just one number spoke to me really was when you said the challenges, and it was the incidence of aggression and violence on the wards, the 6 or 7 a week. Now that's quite significant, I think, and I know you're putting mitigating actions in and supporting staff with more sort of police help, but that's not going to mitigate them happening in the first place. So maybe you can speak to that and maybe what we can do or what we are doing to try to support staff in these sort of very difficult circumstances.
Yeah, I mean, so I think colleagues will be aware that we obviously have a violence and aggression group, which Rachel chairs and I'm a participant in. Each of the directorates has got a strong leader around this work. The reality is that particularly on mental health wards, they are places where we experience violence and aggression. And it comes with it does come with the fact that we are treating the kind of some very, very ill people. I think the report sets out, as you've already mentioned, what we're trying to do to support people after the event, and that's where Cavell comes in. The affinity protocol is something slightly different in that that's about how we work with the police to draw them in when a situation is actually happening. But again, that is something that we would only do in extremis. The real focus, I think, has to be around the preventative stuff. So it's about how you create conditions on the ward where people are kind of spotting what's happening and then working together to try and reduce the potential for a situation to escalate to an incident. I think there's been some really successful work over the years, particularly in the forensic service. And certainly we're trying to draw in some of that learning to places like the Tarn, which inevitably, because of its client group, is a place where we see a lot of our incidents. But that's not to say that they can't be avoided, some of them, because they can. And I think this is the ongoing conversation with the staff there, that some of it is about environment. So, you know, often what comes up is a focus around seclusion, but a lot of it is about practice. It's about how they operate on a shift, how they engage with service users, how they create an environment which is more therapeutic. So if you've ever been onto the Tarn, it is quite often, you can go on there and quite often find the TV blaring, music playing. You know, it's not conducive environment. So there's a number of different levels to this. And I think then that, as I say, that needs to be allied with strong leadership within the directorate. I've no doubt that Aisling takes this extremely seriously, and the welfare of her staff really seriously, as it should be. And that needs to be they need to be replicated. That needs to be replicated at all levels. So we will continue to focus on that. I think the trust-wide group really gives us a focus on what works well and kind of spreading the learning. But yeah, it's an ongoing situation that we're monitoring.
Thank you, Ian. Iffy, please.
Ian, thanks for that. I just wanted to extend on what you've said, and I think your last point about spreading the learning, because this is now a much bigger issue. It's not just about mental health. It's an issue in primary care. It's a big issue in acute hospitals, and I've been part of a group in London just sharing the acute trusts what we've been doing in Oxleas, because they too are struggling with it. Only last week, one of our GP colleagues, Bexley, was complaining to me that they cannot keep practice managers because of the level of abuse they're subjected to, and people just choose to leave and go and work elsewhere. You know, so there's something in society. You will, of course, remember many months ago, we talked at the board about people's opinion on the NHS and the fact that that has dropped. You know, there's something happening in society right now that's resulting in people really, really having a go at healthcare workers. When in fact, you know, we spent quite a bit of time this morning talking about some of the challenges. And as though that wasn't enough, only last week here at Pinewood House, we had a patient who pitched up and insisted on coming upstairs and dragging all the managers down to assault them, you know, which was really quite terrifying for our staff, not least the gentleman at reception. You know, so I'm not sure where we're going with this, but across the NHS, we're seeing this increasingly more than we've ever done before, and there are lots of discussions about how we manage it. And of course, we, like other trusts, are relying heavily on the police in terms of the support they give, both with responding, but also prosecuting people who assault staff.
Thank you, Iffy. Jane, please.
Thank you. Just a couple of points. We've recently engaged with colleagues throughout the organisation through a couple of workshops to try and co-create some awareness posters based on our values and what's really important, that it's not okay to come to work and be treated with abuse or aggression or violence. On top of that, if Abby and Neil and I have been working very closely on what we'd like to do around scaling up and spreading what's known as trauma-informed care and supporting us to be much more trauma responsive, because this is the golden thread that goes through all of our values and everything we're trying to achieve, and it will support that relational security and that deeper understanding, which will help with the violence and aggression. And finally, I was in a really good meeting chaired by Les Green around our body-worn cameras, and our police colleagues were there last week, and the police were sharing their experiences in the journey and how gradually over the years the use of body-worn cameras has changed that relationship and the culture. And one of the things that they were raising, which we need to do more of, is actually learning about positives from the body-worn camera footage. When the cameras were turned on and there was some really effective interactions and use of really good interpersonal skills. How can we again scale up and spread that to people so that they're learning from positive practice? We don't just want to use it for prosecuting people, so we have got other opportunities there. But I have to say there is a huge amount of work going on, and this is one of the highest priorities that we've got organisationally. We don't want anyone to come to work and to be abused. It's not okay.
Thank you, Jane. I mean, a very worrying issues here, and I think echoing Ifing's point about what we seem to be seeing in so many indicators in society at the moment, and the police themselves with their intelligence on what they think might be a serious disorder as we go into the autumn, they will obviously be extremely stretched as well. So, and I think that incident at the front desk at Pinewood, whilst it was one incident, it did make me think generally about security. We shouldn't overreact, but our staff are vulnerable, not only on the wards, they're vulnerable on the front desks as well, and how we review and reflect on that. And Rachel, I don't know if that's anything that's cropped up since that at all, Rachel T, about security for our staff.
Yeah, certainly we're doing a security risk assessment of Pinewood and looking at what the access arrangements are there on the on-call arrangements. And of course, we consider it in all of our units to make sure that the reception, because they are, one of the most vulnerable groups, that the receptionists are properly protected. So yes, it's in our minds.
All right, thanks very much. Anything else at all on that for Ian? If not, thank you ever so much. That was a really comprehensive report, and capturing a huge amount of work that's going on at the moment. So thanks very much to you and to Lorraine for the work that's gone into the preparation of that. We'll do one more item before we have a break. We move on to item 9, and we look at the focus on service inequalities and digital delivery. I think you can assume that colleagues have read the paper, but who's going to present?
Hi, Andy. I think I'm doing the service user inequalities, and then Alison will do the digital. Hopefully that's okay. So in terms of service user equalities, just to kind of highlight a few things, this, as people will be aware of, is building block 4 of our trust strategy. This is the first time that this is coming to the board. And the plan is, along with the other building blocks, to give an update to the board every 6 months, I think. But in between times, it will be being reported at one of the board subcommittees. The slide deck sets out the policy background for this work and how the focus on service inequalities has really been accelerated by the pandemic. And is now very much integrated into planning guidance. The slide sets out our strategic vision, as in what we are trying to achieve. It brings you up to date on the approach we've taken to this as a programme. And really the work to date has been about building the infrastructure to support the delivery. And I'm really pleased to say that we have appointed somebody to lead this work on behalf of the trust. When I spoke to him before I went on leave, he hadn't told his team, so I'm not sure I should say who it is in a public meeting, but I will update colleagues when that is absolutely been finalised. And we've also, alongside that, been thinking about what the work streams we need to put in place to actually deliver this as a programme of work and to deliver the vision. One of the important things I wanted to just highlight is that we've integrated the mental health PCREF, which stands for the Patient Carer Race Equality Framework, into our thinking. And we put ourselves forward to be a pilot trust earlier in the year. The PCREF is something that all trusts will have to put in place April next year, but we have put ourselves forward to be a pilot, as I say. And then finally, the slides talk a bit about gives you a description of each of the proposed work streams and what the proposed actions are, including the leads. And then finally, as I've already mentioned, a bit about the governance of the programme. So there is a more detailed action plan that sits behind this, which is being reviewed by in a group which I chair. The frequency of that group at the moment is every couple of months, but I've been talking to members about increasing the frequency because there is an awful lot to do, and I think to really kind of drive this and get the impetus that it requires, we are going to have to step up the pace a bit. But happy to take any questions.
Thank you, Ian, and I'm pleased to hear that you've appointed someone to lead on this, because it's there's a lot of work involved here, isn't there? Yemisi, please.
Thanks, Andy. Thanks, Ian, for this. And it's really good to see the comprehensive work that is going on in this area, and how widespread is the number of people involved. And as you say, the appointment of somebody to lead this. I just wanted to ask, in terms of, obviously, work stream 1 is data quality and use. And my slight concern is that, is there enough scope for that piece of work to be done quickly enough in order to affect all the other work streams, because it's so vital to all the other work that's going on. We need to ensure that we've got the right data at the right time. And I'm just slightly worried that with the amount of work that we're having to do in terms of data with other streams that we've talked about in the IBR, that work could lag behind a bit. I just wanted to know what your thoughts were on that. Thank you.
Yeah, I mean, you're absolutely right, Yemisi, to highlight it, because it is the basis of everything else we do, is about having information about who's currently using our services. I mean, I think Alison would agree with this, and I'm sure other exec colleagues. For whatever reason, it has been a struggle, I think, within certain services to get good, comprehensive demographic information at the point that people access our services. So for me, this is a kind of a big cultural reset, to use the phrase of Ashling's, that we need to affect very quickly. And I think some of it is about clearly setting out our expectations to staff, but some of it is trying to understand why it is that people clearly find it difficult to ask for some of this information. So I think we can't allow it to take forever, but this is absolutely something we need to focus on. The other thing I just wanted to say is that obviously there's quite a lot of information out there in the wider system about local populations and changes in demography. So we can extract information from that. And of course, this piece of work doesn't just sit in isolation. Each place, so each borough, there is a conversation going on around service inequalities, often about access and differential experiences. So I think we need to do what we absolutely have to do in terms of getting our own house in order, but also use that information that is out there to kind of do something fairly quickly. And that speaks to some of the other kind of work streams. Certainly colleagues like Chaplin are very in touch with some of those local conversations. Yeah.
Thanks, Ian. Suzanne, please.
Thank you. I hope this isn't going to be too long. Preface it. I wanted to stand back a bit and look at this strategically, because my concern is that, having divided the 3 work streams as they are, suggests an assumption that the nature of the services that we're providing are right in the first place. So when we talk about equity of access and experience and outcomes, we're talking about access to services we provide, the experience of the services we provide, and the outcomes of the services we provide, which raises the question for me of whether or not the fundamental point of the inequalities is being addressed, which is that for some people the right services are not being commissioned in the first place. One of the things that really jumped out for me about some of the descriptions of this work is that I think we've forgotten that sex is a protected characteristic. we've kind of fallen into the habit of referring to gender, and because of the sort of issues around gender, which are have been quite alive in the last couple of years, I think we have failed to recognise sometimes, that sex is a protected characteristic, and that healthcare has sometimes been hasn't been well designed to meet the needs of women and girls. So I want to particularly pick up the issue, which I said connected in with our CAMS services. I don't know whether people are familiar with the work that is done by the Alliance for Women and Girls. It came out of a major study that was done on women and girls in the criminal justice system back in 2008, I think. And what it has led to is a recognition that the experience that young women and girls have, including sexual abuse, discrimination, a variety of things which are not recognised, then results in these young people being in the criminal justice system because of the background trauma, which is impacting on their behaviour and so on. The point that they've made is that the 5-year forward view had nothing to say, really, about women and their treatment in the mental health system, apart from the need for perinatal care. The Transforming Children and Young People's Mental Health Provision Green Paper had very little to say about the needs of this particular group. And they point out that the long-term plan has no specific provision for girls and young women, despite noting the particular mental health needs of older teenage girls. This is why I had to preface this by saying I hope this isn't too long. So I think that what I would really want us to do with this is to recognise within our thinking that there are issues which relate specifically to sex that also reflect the impact of intersectionality, so that young Black women in our populations are getting a really rough deal. And then if we were to stand back and say, what role do we need to play as a mental health trust in supporting early intervention? What are the services that are needed for those young women? And I think because there's been a lack of concentration on this in the policy context, it's disappearing from sight again. And I would really like us as a trust to be focused on this, to be raising the issues with the ICS, and to be really clear that this is a group that needs to be thought about, because they are constantly being overlooked and missed out, and it creates such appalling life outcomes for them that it's something that I think we really need to think about.
Very, very well put, Suzanne. Ian, do you want to come back on that point at the moment?
Yeah, I certainly like to respond, but I know if he also wants to come in. But I mean, briefly, Suzanne, I couldn't, I absolutely wholeheartedly agree with you. And I think it's interesting to step back in the way that you have done and kind of speculate, which I think you've successfully done, that it is partly caused by a policy vacuum. Because when I think back about how we've responded to the issue of sex and kind of specific needs, we've done quite a lot in the past, but the focus hasn't quite been there recently. And I suppose just a general point from me that I think with the we've got a kind of new team which we are forming around inequalities, and I think bringing back sex onto the agenda is really, really important. You can have conversations with about sex and gender. They don't have to be, mutually exclusive. So, yeah, I would agree that focus that you're highlighting absolutely needs to run through this. So we can certainly take that away.
Thanks, Ian. Do you want to come in at this point?
Yes, thanks a lot for inviting me in, and thanks, Suzanne, and also Yemisi, for your question. I wanted to start by touching on Yemisi's question, just to add to what Ian had said, about demographic data. This is a cultural change for the NHS. I don't know about colleagues on the board, but I have received text messages from my GP surgery asking me to indicate my age, my ethnicity, etc. So right across, this work needs to be done. And Ian is absolutely right when he talks about using the data that's at ICS level at place, but also providers, giving the emphasis on equality, will then need to make sure that we have a good understanding of people that we've got within our services, and therefore where the gaps are. The other thing I wanted to say about your comment, Susan, which I think is really right in terms of us assuming that the services we provide are the right ones. But one of the things that we've done in the past, and I'm sure we'll do again, and I hope that we will, is to run focus groups. So it may be about thinking about populations that we serve, where the minority groups, where the people that we know are not present within our services, and how do we then engage them in discussions about what they would like us to do differently. Of course, that then will result in commissioning discussion, but that's the whole purpose of the ICS. I think your point about women and children is right. As it relates to mental health, you couldn't be talking or asking a better person, Ian, who is at the ICS executive and the lead for mental health. So I'm sure he'll see to it that happens. But also, I think that as part of our mental health board, that we need to work with SLAM across the ICS to begin to address some of these gaps, and where there's good evidence that we need to do more than we need to. Your point about women more broadly is interesting, because on Radio 4 this morning, there's a lot of discussion about HRT and the fact that it's not readily available to women. My view, as I thought about it, was what is our contraception and sexual health team doing? Is there a role that they can play, even when there's a gap, be it a gap in policy or practice? How can we rise up to this challenge to help meet the needs of the wider population that we serve? So there's so much we can do. For me, the excitement is that we are actually having these discussions, because we never did until COVID hit. So I think that if we think 2 or 3 years from now, we'll be in a much better place. So this is really good, to my mind at least. Thanks.
No, well said, Iffy, well said. Stephen, please.
Thanks, Andy. Yeah, I'm glad the embassy raised the question about data, because I know it always sounds a bit boring, but particularly on when we get into the subject of inequalities, it's everything. And as Ian said, the information's out there, but here's my concern, that is, first of all, we're going to be dealing with a huge amount of data. The NHS will be generally, we will within Oxleas as a little microcosm of that, and within the ICS as well, a huge amount of data if we're going to make these programs effective. So my concern is that that will come in multiple formats, because everyone won't be capturing the data in the same way, or inputting data in the same way we do. And so that reflects on our ability to collect that data and interrogate it. And if we're not able to interrogate it effectively, we've got a problem, because we can't really make any meaningful decisions. So my first question is, have we got the resource to do that? And my gut feeling is we haven't actually. We'd be tinkering about with one little bit of it. And I think we should be probably looking to go outside on that, or work more effectively within the ICS. I'm not even sure the ICS as a whole has got the resource actually, but anyway, I throw that out there, that I think we need to invest a little bit more on that. No doubt, I see Alison's put her hand up. She'll have a view. And then the second thing, stretching forward onto the whole thing about inequalities, and I remember the point that Jane Wells made probably about a month ago, Jane, on one of the NHS strategy documents, about she was disappointed at how little had changed. If you go back to Marmot's book about the health gap, in 8 years, everything that he found all that time ago is basically still the same. And so the question back to you, Ian, is really, I think, in terms of managing our expectations, how realistic is it for us to see some meaningful outcomes? How quickly? You know, my gut feeling is that we're talking of at least a decade, maybe a generation. Although I guess we'd see some directional figures. But I think it would be, and I know you have answered this question before, but it'd be handy, not maybe at a board meeting, I don't think. But just to get your thoughts on, in terms of inequalities, you know, how quickly do we think we're going to see some data that shows we're going in the right direction? And coupled with that, are there some areas where in fact we could make and see quick outcomes? I'm not sure that there are, but perhaps you might give us some examples of, yeah, within a year there's this particular area where we could see you know, that we're going in the right way. And I'm only saying that because otherwise there'll be frustration, I think, within the non-execs and the board to say, well, that figure has only changed from 10.1 to 10.2 over a year, and in fact that might be a fantastic change, but it might take a long while before something meaningfully happens. So two things there: do we have sufficient resources to collate the data from multiple formats and interrogate it properly and draw conclusions? And my hunch is we don't, in which case we've got a decision to make about investment. And secondly, manage our expectations on inequality progress.
Thanks, Steve. I mean, I'm happy to attempt an answer at both. In terms of the first one, Alison, I'm sure will add to it. I mean, I think you're right to raise this. There's one thing having data. There's quite another in terms of having intelligence. And so, what does that? You know, what is this data? What is it actually? What is it actually telling us? There is an ICS level conversation going on at the moment, alongside a focus on service inequalities. As everybody will be aware, there's also quite a lot gets talked about around this concept of population health, which often the two things get talked about in a kind of interrelated way, and frankly, often in a quite meaningless way. But I think there are some good conversations starting to happen at a sort of ICS executive level, and I'm sure it's also the same at the board, about how you might grow that capability in terms of having people who can derive this information and then do something meaningful with it. That does take into account the need for investment. And I think what's quite interesting is that there's a lot of people who want to do this work and actually would rather do this than the kind of some of the work that they're currently involved in. But they need to be released and they need to be trained up. So I think the actual vehicle for it and how it's going to be funded is being debated at the moment. I mean, Alison, did you want to? I mean, you and I have talked a little bit about this. You're probably involved in some more of the detail, but.
Yeah, I mean, I was just going to pick up on the broader point around how we share information around the ICS. As people are probably aware, of the last 5 or 6 years, we've been developing what is now called the London Care Record, where certain clinical information is shared, and that's morphing into a much broader project around London Digital Data Services, where information, much broader set of information, will be shared across the patch, and that brings its own complexity because, as I think was mentioned, we don't all store information in a standardised way, and that's really key to sharing information in the future and using that information for population health and for analysis. But there's certainly the infancy of a plan to have a much broader data set available to staff within the ICS. But I think it will take time. I think you're right, Steve. You know, that's a 5-10 years away before we really get a huge amount of clinical data available that can be used for improvement. But certainly within the organisation, we've a lot of the demographic information and the inequalities information is available to staff through iFox, but we know that that's not particularly up to date in many of our services. So there is a piece of work to ensure that we start to capture that information regularly with our patients to start with.
I mean, thanks, Alison. And in terms of the second question, which is about having some kind of measures of success, I mean, you're absolutely right to highlight this, Steve, and this is the dilemma I think myself and other people involved in this work are feeling that we're talking about something which is, you know, the issue of inequalities is inherent across society. We're trying to affect one bit of it. So broadly speaking, this is going to take a long time. Having said that, I think we've tried to pick work streams which do help us to deliver on some kind of quicker wins. And there are some markers of success we could use. So for example, one of the things that I am very preoccupied about, and it's front and centre with the mental health PCREF, is around things like the rates of detention and differential rates of detention for the people from different communities. So that is a measure. If we can present information broken down by different communities around that to, say, the board, would be helpful. If we can then demonstrate a reduction for certain communities, that would be helpful. But the actual work to do that is way upstream, and it's about how you engage people from different communities in treatment in the first place. So I think we can come up with markers of success, but the work to actually kind of achieve that success may take a bit longer. But hopefully by the time I next come to the board, we'll have a much clearer set of measures that we can that we can discuss.
Thanks, Ian. Jane, please.
Thank you. I was just really interested in Ian's comment around the population health and the inequalities, and it doesn't easily or naturally fit together. I think we have got an opportunity here to look at health, population and inequalities and our services in a really different contextual way at the moment. And an example where I think we can look at one of our services, the Looked After Children service, using the sort of lens that Suzanne has offered of intersectionality, but also through teenage pregnancy, because we know that nationally teenage pregnancies have significantly dropped since about 1999 with the long-acting reversible contraceptives by about sort of 60–70%. But if you look at our services and our boroughs in Greenwich, Woolwich, Glendon and Abbey Wood are significantly higher than the rest of the population, and we've got a lot of poverty in those areas. We've got a number of looked after children, we've got a number of children being truant, we've got safeguarding issues, and we've got a lot of sexual abuse and crime there. So I think we can make a big difference, and we can look at specific services within the context of inequalities and population health. And it's such a shame that we don't have our health visiting services here, because this would have been bread and butter for them. But I think we've got an opportunity, and I just wanted to add to that.
Well said, Jane. Thank you. Rachel, please.
Thanks. So I agree with all that Ian has said, and it is clearly tremendously difficult to commit, I think, to linear improvements in any of these areas when we're looking at access, experience and outcomes. But, you know, exactly as Ian says, there are areas, I think, where we should hope to see some improvements within a specific time. The question about investment and whether we have the right resources in place, and I think we need to be careful here to think about the fact that this isn't about necessarily bringing resources into Oxleas to do more of this work. Often it's about investing in the local communities who are closest and know their communities really well, and for us to help them to help us to make improvement in these areas. So I just think we need to think a little bit differently about the relationship between us, patients and carers, and local community groups to try and get that kind of triangle that can work really effectively.
Yes, thank you. Thanks, a really good point, Rachel. And there is a fair bit, as you said in the chat, about the ICS. We certainly discussed that in some depth, I think, at our meeting at the Oval. So, and they do have resource, let's not forget, within the ICS, some considerable resource. So maybe that's an area we should start to look to see how they can assist with redeploying some of their staff to the front line. Right, Alison, you're going to come in at this point?
Yeah, thanks, Andy. What I was just going to do was just share the presentation and do a really brief canter through of the slides, appreciating that everyone's seen them already. Just bear with me while I open that up. and then take questions afterwards. So as people know, building block 7 is one of the 8 building blocks that supports the trust strategy, and we've been developing building block 7 alongside our broader digital strategy that we launched back in 2020. So just thinking about the case for change for building block 7 and the work that we're doing, we obviously know that there are many opportunities to use digital to support patients away from hospital, and we've been seeing how clearly that's been used to good effect during the pandemic. We know that also we've got lots of issues in terms of population growth in South East London, and also thinking about our staffing issues that we have at the moment, and how digital might support all of that. So I know that Ify and I were talking a little while ago now about how we might use virtual appointments to support some of the work we're doing around waiting lists, maybe having clinics in the evening and weekends, and staff being able to do them from home on bank, which would supplement obviously the wages, and would enable us to move more swiftly through some of the waiting lists where that would be appropriate. And if we think, as I mentioned, we've got a much broader digital strategy, but the 2 main building blocks within that strategy are focused on connecting up our patients and connecting up our workforce, and there are a number of key enabling building blocks below that. But really what I want to focus on are some of the key successes that we've had over the last year. So we've talked about it quite a lot in terms of connecting up our patients, and over the last year we've launched Oxcare, and we've seen quite a number of patients sign up over the last year. People might remember that we got funding from the GDE programme which is the Global Digital Exemplar programme, to fund the Oxcare project. Within that programme, we said that we would aim to get 562, which is a bit of a random number, but 562 patients live by the end of year 1, and I'm pleased to report that we'd reached that target by the end of July. We've also been focusing clearly during the pandemic on the use of digital appointments, and we know that many of our staff have been using video as well as telephone appointments to connect with patients during the pandemic. And so one of the stats that I put in the slides were around the use of digital appointments. So prior to the pandemic in 2019, we saw 288 appointments being used by clinicians with their patients being recorded, and that jumped to 74,000 in 2021, and that's kind of retracted back to 53,000 in the last year, 21-22, and a lot of that's because we've had more opportunities over the last year to interact with patients face to face, but it's a really significant jump, as you can see, from where we were pre-pandemic. We've also been focusing on, increasing staff confidence in the use of video, and we've been running surveys recently in Attend Anywhere to garner feedback from our patients, with over 94% of the patients surveyed saying that they'd be happy to have an appointment, a video appointment again. So if we think about how we've been helping the workforce and digitally connecting the workforce. Again, we ran the same survey through Attend Anywhere to get the views of our patients, of our staff, and we got 665 staff responses, and almost all of them were happy to continue with video calling as an appointment, if it was clinically appropriate. And then if we think about just some of the key successes of the building blocks that we've been working on, over the last year we've been rolling out team dashboards to many of our services, and that's resulted in a significant uptick in the use of iFox across the organisation. We've gone from nearly 700 regular users of iFox to over 900 over the last year, which represents a 35% increase. We've also seen a huge amount of recording of electronic observations within Rio, and that's really beneficial because no longer will we lose observations when we come to maybe take a look at them for a serious incident. It's all now recorded in Rio, and that's for both physical and for mental health. We've also clearly been doing a lot of work during the pandemic supporting smarter working, making sure that staff have got the right equipment for their roles and to enable them to work in different ways during the pandemic. And one of the figures that I have that actually isn't in the slide here, it just relates to the reduced travel expenses that we've seen. So in 2019, we spent over £1 million or nearly £1 million on travel expenses, and that's reduced to just over 500,000 in 2021 and 2022. And it'll be interesting to see what it will be in the next financial year. In terms of thinking about how we support all of the different big priorities, we've been doing a huge amount of work supporting the waiting list initiative, working on the systems that we've put in place to manage both the simple wait lists that we have in services and the multiple waiting lists. And what we're aiming to do, and we've just been finalising this piece of work, is establishing the metrics around the first metric around waiting lists that will go into iFox and will be available in a standard way as we roll out the waiting list functionality across the organisation. At the moment, we only have functionality for simple waiting lists, and we're working currently with our supplier to introduce multiple waiting list functionality, which will mean we'll be able to roll this out across all of the organisation. We've got some UTS, some Unified Tech Fund money to enable us to do this, and we're hoping to have that ready by the end of the year. We've also been working on continuing to work on our infrastructure. I think that's really important, especially in the light of some of the cyber incidents that we've seen over the last few months. And as everyone knows, we've had an increased focus on cybersecurity over the last year, and we launched our cyber strategy back in March, April time. And we've also been thinking about how, particularly through the pandemic, we can make it easier for staff to interact with our help desk. And there are some changes that we have in place focused on that will be introduced soon. So I really just want to spend just a little bit of time thinking about where we've come from and the work that we've got planned for the future. So we're now starting to think, as I mentioned earlier, about the staff who will support all of the work that we're doing within the directorates, and how we can really bring about a shift change in the confidence of our staff to really embrace all of the digital opportunities that we have on a wider scale. We've seen this. Sorry, just bear with me 1 second. Just bear with me 1 second.
I don't know if we've lost Alison there.
Sorry, I was getting connectivity issues.
Okay.
Sorry. So yes, so where was I? So yes, sorry, I was talking about the confidence of our staff to really embrace these digital opportunities on a wider scale. So we've seen, we sort of started seeing this with rollout Oxcare. We see people who can really run with Oxcare, and then we see staff who perhaps are more cautious about recommending Oxcare to their patients because they really don't know or understand how Oxcare works themselves and how they might use Oxcare with their patients. So we've been investing in the clinical leadership, or we're going to be investing in the clinical leadership roles that we've been talking about recently. And we've also got some investment in some additional temporary Oxcare resources too. But what we're planning to do going forwards, and what we've been talking to the exec team about and the infrastructure committee about how we might do this, is we're thinking about taking some pathways within the organisation and putting an MDT team around them. So what we're thinking is that we might have, I don't know, a RIA resource, an iFox resource, and working alongside these new clinical digital leaders and the clinical teams to think about how we might create a digital pathway, or perhaps a hybrid pathway. And from that initial referral into a service, how we offer a standardised approach to a digital pathway alongside a face-to-face pathway. And we know that patient involvement will be really critical in the success of this work, and we want the involvement on a big range of patients. And again, we were talking about this at infrastructure, not just those patients that are really keen on digital pathways. And again, we've talked about a lot of this in the past, but it's really kind of just putting that team around service and seeing how we might create a digital golden thread that will supplement the work alongside that hybrid pathway or that face-to-face pathway for a team. And so there's clearly implications of that for our estate maybe in the future. And Rachel and I have been discussing about how we might work and feed that work into our future estate strategy. And so, I mean, I guess we're really just quite excited about how that might work. We really want to get these clinical digital leadership posts that we've got funding for in place, along with the Oxcare resources. So we think, but early in the new year, we'll hopefully be in a position whereby we can identify some services where we can take that approach, and then we can take the learning and hopefully broaden that out across the organisation. So that's certainly something that we're planning for the future, kind of building on all the work we've done today, and certainly something that I'm really excited about, and happy to take any questions.
Thank you, Alison. Any questions for Alison on that? I mean, I know we've spent quite a long time on both of these topics, but I think absolutely vital, and it's been really interesting to see the level of, or gratifying, the level of interest and concern over these matters. Stephen, please. Well,
Page 74 of the bundle. I know unusual times, 53,000 video appointments. That's sort of in a semi-post-COVID time. That is one of the great step changes that Oxleas ever made. So take that page out and frame it. Two questions for, well, not necessarily for Alison. In terms of future developments, should we be thinking about a 24/7 service? Because for a number of mental health patients, you know, they don't get their issues necessarily in the nice office hours we may work to. So is there scope and potential for that? And secondly, in hospital assessment suites, should we be thinking of having more video facilities there? Although I do appreciate that for a lot of our consultants, they would say nothing can beat actually physically seeing a patient. But I'm just wondering, is given the estate costs of creating an assessment suite, a proper assessment suite, whether the use of a video facility again makes it easier to work that on a 24/7 basis, and probably reduces our costs quite substantially. So mixture of questions for Iffy, Ian and Alison on those 2 points. But the basic thing is, you know, I know the figure went up to 74,000, but I must come back to the 53,000, you know, when things were improving. That is an incredible figure.
I totally agree, Stephen. That's really excellent progress. Iffy, please.
Steve, thanks for that. And in fact, I don't think that Alison did justice to the aspect of the future in her presentation, because I know that she and Rachel have been meeting with teams, really asking those questions about 5 years from now, 10 years from now. How do you think you will operate, and what do we need to put in place? Your question about 24/7 is an interesting one. Certainly what I will say is that it used to be the case that in severe mental illness, you know, those outpatient clinics often start at 9 o'clock and nobody ever pitched up, until clinicians began to realize that most patients either don't sleep at night and don't roll out of bed until about 12 noon and move to their clinics to the afternoon. I think there's a debate to be had on that as to whether you support people who ideally ought to sleep at night to be refreshed, to feel better, by engaging them in clinical consultations. But I'm sure there's something we can do about that. I think your point about what we put into the fabric of our buildings is a really good one, because I know that when we're building our health-based place of safety, we talked about how might we install within the buildings, Jane knows, monitoring, so that we don't necessarily have to expose our clinicians constantly going in at the risk of being assaulted or whatever, to check if people are breathing or if their temperature is right, etc. And I would quite like to see some of that kind of remote monitoring going forward, if we ever get to the point of being able to build new and modern facilities. And then finally, the video thing, mean, I couldn't agree more with you. You know, I remember 3 years ago, Alison and you at these board meetings constantly saying, you know, can we do more video consultations? And people are saying, oh, no, no, no. But I think they're here to stay, and we just need to be very clear about what groups of people and therefore in what service lines or teams we can roll those out. And I think that clinicians have quite embraced that. What I hear, not necessarily within the NHS, but outside of the NHS, is that most of the therapy that now goes on is virtual. People don't necessarily want to sit in offices and have face-to-face consultations, because it then enables people to access a wide and geographically distant experts who are best placed to help them. So I think that this space is really quite exciting, and I can see that there's a lot that we hopefully, if we're sat here, not necessarily with the same people, but we're sat here in 3 to 5 years' time saying, thinking about how far we've come, you know, we would say, wow, did we know we could get here?
Thanks, Iffy. I always worry about this 5 years' time. It as one gets more mature, and echoing Stephen's point about, you know, what can we do by when, and I do appreciate it's a huge issue, and that's reflected the amount of time we spent on this. Last word from you, Alison, please.
Thanks, Andrew. Yeah, it was a similar point to Iffy, really, just thinking about how we use the data that we have to change the way that we provide services, and the example about, you know, whether or not we should change services as a result of DNA. So, you know, we know that we provide DNA information within our IFOX reports on team dashboards that staff see. So, you know, should we be doing QI around why people don't attend, and then, you know, can we tailor our service accordingly? And that probably comes back to some of that work that we want to do around tailoring tailoring the work around looking at our services, the digital services, creating that digital golden thread. You know, are there more opportunities to supplement video along with face-to-face, perhaps have more interactions with our patients rather than less, and supplement face-to-face with digital? But could we, you know, use the data that we have to maybe change the way that we provide our services and tweak accordingly and make them more personalised to different patient cohorts?
I think that's absolutely. I mean, I think this has been a really interesting, both of these topics, and we have spent a long time on it. I think absolutely justified, and it shows the degree of interest that there is in this and the importance to our patients and to our staff. And perhaps we might look at one of our development days. I know I'm always in danger of filling those up with all sorts of topics, but it's one that is clearly a lot of interest in. And I think colleagues would probably want to discuss these things, you know, from time to time as we see how these developments unfold. If anyone points out how long these meetings last, please reflect on the amount of interest there's been in this topic. I did get some feedback on my 360, but I just remind colleagues that this was really, really interesting and huge contributions from everybody, which I think were absolutely justified. Right, now Rachel will tell me off if I don't allow a decent break. So what about the 1300 colleagues? Was everyone happy with that? We come back at 1 o'clock. Is that all right? Good, brilliant. See you at 1300. Thank you. We'll make a start. If we now go on to item 10, which is agency cap, and Rachel, please, and Ezra.
So I was going to start, if you don't mind, on this one, Steve. So if I present just a summary of the analysis, I'm going to take the paper as read, and then Rachel can come in to help support a little bit more, really focusing on the vacancies and the retention work that we're doing within the trust. So effectively, what we've got marked here, this paper was generated coming out of presentation of the month 4 finances to the business committee, and the recognition that we were then beginning to see a fairly regular breach of the NHSIE threshold that we had been given for agency. Coming out of that discussion, a paper on both the agency spend and the bank spend usage and a forecast through to the end of the year was requested, along with some analytics on the drivers. The reason that the paper was originally put forward, and there was an issue that was felt at the business committee, was because one of the drivers and one of the prerequisites for the additional funding coming out to allow most of the NHS to put forward break-even plans was the fact that they had to meet all of those NHS organisations, or ICBs, had to agree to the fact that they would do something about agency costs. I think in context, what we need to bear in mind for our trust is a very large proportion of our agency costs are driven by clinical and quality needs within our services, because they're actually driven by vacancies. Overarchingly, as at month 5, for example, we are £2.6 million underspent on pay. So even though we're using higher levels than we ever have done before of both agency and bank spend, that is still not actually meeting the overarching requirement that we have for pay. And as a result, I think we would find it extraordinarily difficult to bring those back, because unlike, I think, some other organisations, we at Oxleas, pre-pandemic, had actually a very robust bank and agency framework that we were utilising. We maintained that through the pandemic, and therefore we've got a set of controls that would be at the top end of what people would be expecting to see in terms of management of those, and we've continued to have those right the way through. That includes sign off by the medical director of any agency spend that we've got above the actual framework cap of £100 per hour. That's also then signed off by the chief executive. We look at all agency spend other than those that are linked directly to safe staffing. So you'll see that band 5, band 6, band 2 and band 3 clinical staff do not come to agency panel. And that is because there needs to be an assessment that's fairly real time that occurs in each one of the wards of the areas that we have 24-hour services in operation, to ensure that we have enough staff in order to provide a safe service. And there's no way that we'd be able to do that in terms of an agency panel, because often those requests will come out of hours as we discover that we've got a shortage of staff. So I think it would not be practical to be able to strengthen that element of our overarching agency controls. Key features effectively to bring out is we've had some step changes in regards to the areas that we have used agency. One of which is the new prisons contracts that we've come on. We've already talked about it earlier on in the agenda. We have had extremely high vacancy rates across a range of those new prison contracts that we took on, and we had to find temporary staff wherever we could find them. That is a combination of an increased use of bank, including using gold rates for some of those bank shifts, and also accessing as much agency staff as we could get hold of in order to try and bridge the gap of the very large vacancies. We've continued to see, this is a feature that we saw previous, but it's continued, and I would say is exacerbated in our medical areas and our vacancies that we've got within those areas. They are increasingly difficult in a number of mental health areas, one or two areas within physical health, and definitely still within some of the prison environments and pharmacy in particular. We've really struggled because there is a national shortage. We're in direct competition with a whole variety of other organisations. So there's a real issue with supply in those areas. And that has meant that we have got a very active agency market that we are then actively trying to pursue and bring people forward. We've got, so vacancy is one area across a number of hotspots. We have got the prisons, which has been an issue. Then we had 1 or 2 areas that were outside of that. We had agreed to host an NHSE programme for 111. That has ended up being very largely staffed by agency members of staff. There's about £1 million that's associated, just under, with the forecast against that programme if we have a continuation of that going forward. The prisons is a very significant amount, and you can see it listed out within the paper in terms of the figures. And also, as has been indicated earlier on, we're going to bring online a new mental health ward, or reopen a mental health ward from November. The paper has estimated that to be £1 million because we'd assumed it started in October. If it starts in November, it moves from 1 million to 833,000. So it's still very significant. Just to point out, that is not a ward that is completely serviced by agency members of staff. What it will be doing is it will be staffed by permanent and some temporary staff. But in order to have the permanent staff there, we will have to take them from other areas, as well as be proactively recruiting into those wards. So those were the key drivers. I think it is worth noting on page 87 of the pack, if we look at the ICS position and the position that we see in regards to SLAM and how much they have overspent against the threshold and the plan that we have, they are seeing those issues happening in mental health, where I think some of our vacancies are at a far higher level than we are seeing in some of our acute colleagues and the vacancies that they are actually having to deal with. So both of us are going over that figure. We've had the discussions at ICB, Directors of Finance and CFOs, and the view is, as an ICB as a whole, and I have to say as the NHS as a whole, it is going to be difficult in order to be able to bring down agency costs with the level of vacancies that we are currently dealing with. Some of the issues that we've got in the acute sector around backlogs and trying to address some of those needs will require temporary staff in order to do so. So this is the direct match off between agency thresholds, spend against those areas, and actual service delivery, and really making a difference to the waiting lists. And that is one of the drivers, although I would say at a lower level, in terms of why both our agency and bank spend has gone up over the course of this period. Because I'm going to assume that people have read the paper, I was going to stop there unless there's any direct questions. And then I think maybe take the questions now, because I think that's around the drivers, and then we can move on to what we're going to be doing in terms of mitigations going forward. Does that make sense? Are you comfortable with that, Andy, as a way of taking that forward?
Yeah, that's fine. Thank you. Nina, please.
Thank you, and thank you, Azra. You have outlined everything in a really comprehensive way, as always. I have 2 very specific questions. The first is, am I correct in saying that it's the ICB that's held to account for breaches to the thresholds on a South East London basis?
It's the actual control total was given to the ICB, and then it was allocated out to each of the trusts based on their plans. But okay. It is the ICB that's held to account. But we're all part of that, clearly.
Sure. My first question is, what is our response to the ICB when we explain that one of the key drivers for the change is our expansions into prisons that are not in South East London?
So in both of those, I directly raised those with the ICB CFO. The 2 areas that I raised was the fact that we had a hosted service that was generating, I mean, there's about £1 million of the breach that we're talking about, the forecast breach, is linked to that programme. On the prisons, you can see that that's a very significant driver, and I have specifically raised that issue again with the ICB. And in both cases, I was getting cover, I would say, from the ICB CFO for the reasons for why that was occurring. And I think in reality, when we look at it and we look at the quality and safety issues of not using agency or bank, they would outweigh whatever we had on the threshold. So I think we would have a very robust argument if actually the whole ICB was called into account in regards to our areas of overspend, especially in the context of the fact that we're actually underspent on our pay budget.
Yeah, and I don't dispute the very strong argument for patient safety. I guess what I'm struggling to get straight in my own mind is how does this fit with the South East London system that we are a part of? So maybe that's something that we can explore offline. My second question was, you're asking us to approve a 20% overspend. Do we know what other boards who are in the ICS are being asked to approve?
So I don't think any of the others have actually taken it to board, because I think they have simply said, if we breach, we breach. The reason that we're breaching is quality. And that is the nature of the discussion that we effectively had at ICB CFOs. So a lot of the others haven't actually taken it to their boards as saying it's a breach. But if you look at page 87 and the position as at month 4 on agency spend, there's only really 2, I would say, that are expecting, well, 3, of which, and at the time, the forecast that we have here is understated. So where it says currently 12.3, when we did this particular piece of work, that figure has come out to be closer to the £13.5 million figure, and that is what I think we will end up going to. We're second highest, with SLAM having the highest level, so they've seen it. It's been discussed. This report and that extract would have gone to the overarching ICB executive. So they're cited, and I just do not think that there is the level of concern, certainly not that they would take away any funding, which was the initial particular barrier that was put in place in terms of the whole of the NHS being able to access those. I think the key concern nationally, just to put this into context, the key concern nationally is that they do not want to have a return to the days pre-2015-16, where it was almost a wild west of the agencies, and the NHS very much being at their beck and call in regards to what rates were being applied. Since that time, we've got a range of frameworks that are now in place. That means that we're at least got a stable negotiating position from. There are 1 or 2 areas that we really struggle with in terms of rates. And I'm going to say the highest, there's probably 2 main categories, medical and AHPs, of which I would say medical is the highest. And that is because supply and demand is most out of kilter in that particular reaching price. It's about volume.
Okay, thank you, Azra.
Yemisi, please.
Thanks, Andy. My question follows on from what Nina was saying, and Azra, to a certain degree, you have touched on it. And it's about the prisons contracts with the significant vacancy rate and the forecasts. And you did say that what's in the paper is somewhat understated, and actually you're expecting it to be more. My issue is I actually think it's very understated, and especially since we don't fully know the true picture of our new prisons contract yet as to the severity of those vacancy rates. How would you respond to that, that actually those forecasts could be a lot higher in the actual by the time we come to the end of the year, and what would your mitigations be around that? So considering you're now asking us for 20% overspend, are you envisaging a time that actually you have to come back and it could be significantly higher? Thanks.
So I think the one key unknown that we've got now is really what's going to be coming out of the South West England bids. I am confident of the areas that we currently have. So for Kent and for our existing services, we've got a robust forecast at the 13.9 million, actually not 13.5, that we've got articulated on page 83 of the pack. That is what the forecast outturn currently is looking like. We are seeing some of the areas having a bit of a reduction in the agency spend, but the reason that we've left that at that higher rate is because of the unknown that we've got coming out of South West England. And I think the key issue that we need to be aware of is when we took over some of the contracts on the Isle of Sheppey, and it only really came out, I'm going to be honest, round about April, because the TUPE list was not exactly in place in regards to the fact that a number of those services that we inherited from IC24 were completely dependent on agency staff. They had been using them for a significantly long period of time, and they had a particular rate that they were using them in. So we continued with that going forward. Now that's going to be one of the lessons learned as we go into the South West England TUPE and exactly how we do the transition. But we've only really had the beginning of sight of that for lot 1. Lot 3 and 4, we've still got a way to go before we're going to get visibility. So we may come back at a later date to say there's going to be a higher breach. Although what I would say is, I'm not sure we would necessarily need board approval for if we go higher. I think the principles would be really important at this meeting to establish of if it is around quality and safety, is the board comfortable that, and as long as we're not going over the pay, which I'm going to say highly, highly unlikely, are we going to breach and overspend on our pay budget coming out of all of this from a finance perspective? Would the board be comfortable with that, bearing in mind when we get to that section of the discussion, the mitigations that myself, Rachel and the executive team are hoping to put in place to try and improve that position, which is really about recruitment, retention, and what we're going to be doing on rostering. I hope that answers your question.
Thank you, Ezra. Sue, please.
All right, thank you. Just a quick couple of points, Ezra. It's in terms of the agency staff, obviously you have to employ to fill the gaps, especially in terms of clinical staff. Do you have a fixed rate with them so it's not coming like a circus, so the staff will go to the highest rate for them?
So we have a framework, we have a set of frameworks that we use that have fixed prices for them depending on what grade of staff. If we go outside of that framework, there needs to be approval. And the point that I've mentioned is the key one that we're going outside of those rates, I would say, on a fairly regular basis, but it's for a very small number of people, is for medical. And in each one of those, not only is Abby signing those off, but Iffy, as chief exec, is signing off what those rates look like. And we do have that discussion at the agency control panel. So it's not as if they just go through and there's no oversight. The oversight is given by both Abby, Iffy, and that agency control panel. But there have been occasions that, yes, we have breached those price caps.
Yeah, and thanks. A follow-up question, perhaps I'm just being ignorant here, I don't know. In terms of obviously what we've heard throughout this morning with the pressures on staff, the fact that, if I recall correctly all the press statements we've had, there's a wish or desire to increase the bed numbers across the NHS. How would then that be met if we haven't got the staff to do what we're doing, and the increase to cost of that, and how would that be built into that so that as a trust that does its best for the people it's caring for, not be broken in terms of finances? A bit of a long-winded question, but I hope you understand where I'm coming from. Thank you.
So I'm going to start this off, but I'm probably going to bring in a combination of Iffy and Ian on some of those, and Rachel may also want to comment. So I think start point one is the reason that forecast is at 13.9 million, or just under 13.9 million, is we have factored in the opening of that new ward we had talked about earlier on. So the increase in the mental health bed base, we've got covered off within this forecast at the kind of worst case scenario. So we've said everybody that comes in, we take at the very top level of whereabouts they are. And I think we'd already done the assessment for the fact that we're highly likely to have to breach the agency cap to get the medical cover in order to make those wards work, until such time as we're able to recruit. But I think that was the key challenge that Ian had been referring to earlier on in the board, around the fact the biggest risk to the opening of that ward was always going to be getting the staff. And this is the issue I think that we have right the way through. People would not want to be having the level of waiting times, etc. As staff members, that is not what we would like to see, but often we're capacity constrained by how much workforce we can get in and how quickly we can get them in and then retaining them. I don't know if other exec colleagues wanted to come in just on those points.
I think we get the thrust of the debate and the where you're coming from on this one. Quite clearly, there's an overriding requirement on quality. We face incredible pressures on vacancies, and if that is the trade-off, then, in my opinion, there's something you need to get on, and if necessary, breach that cap. Look in the context of every other trust in South East London as well. And I think the prisons does put a different dimension on it, out with the ICS. And I think I'd be very happy to argue on behalf of the trust at any arena, given all the mitigations which we can read and we've got. And I know we're a very prudent organisation and we'll do our very best to keep it down. But my take on this is, and I can't talk for colleagues, but my take on this is that I'm content for this to be agreed and for you to get on and deal with it as appropriate, subject to the usual good governance that you always have in these circumstances. I mean, have colleagues got anything more to add? Iffy, do you want to come in on that?
No, I think you've made exactly the point I was going to make, which is bringing it here is just to inform the board, assure the board, and reassure you through the content that we're not just sitting there recruiting agency, we're doing additional work to address the gaps we have with staff.
Thank you. Last word. Sorry.
Now, I was just going to say, and lastly, talking to my colleagues, no one else is doing this. And certainly we don't know of any other, I don't know of any other boards where the exec have decided to take something to their board. They're just getting on. So this is just us thinking this is the right thing to do to discuss.
Yeah, and as chair, I want to make sure you've got the necessary air cover to get on and do it. Last word, Jim, please.
Very quickly, just an understanding, if you have it now, as to what happens going forward. Is this in terms of the recurrent and non-recurrent drivers? Is this going to happen every year? Are we expecting this to happen every year? Well, next year as we go forward. So which elements of this are business as usual? Which elements of this are one-off for this year?
So I'm going to say I would hope the prisons would improve, and we have seen that in some of the contracts that we've already got. But it may take a while as we bring on the new prisons to be able to achieve what we have achieved in Wandsworth and in some of the other areas. I think medical is going to take a while for that entire market to stabilise, so I would probably say that will be a continuing feature. Some of the AHP issues I think will be continuing features. And then through the range of areas that we're looking at under the workforce executive group that we've got, which is looking at exactly how we make ourselves more attractive on both recruitment and retention. I think we'll have step changes, but I'm going to say they are going to be slow coming through because our fundamental issue is we do have a demand and supply issue.
Yeah, thanks, Ray. It's a very good point about the future there, Jim. Consider underspend on staffing at the moment, and that's quite clearly what the issue. We've heard the arguments. Ned, colleagues, satisfied and agree? Agree. All right, lovely. Well done. Thanks very much indeed. We'll move on now to item 12, race equality standard and disability equality standard, please. Rachel, thank you.
Thanks very much, Andy. So what you have in front of you is the work plans for our workforce race equality standard and the workforce disability standard, what we call the RES and the DES, and they follow up the reports that we brought in July, setting out our progress. And you'll remember that we had a really good discussion then about where we are and where we want to get to. You've got the action plans in front of you, and you can see that we are trying to do a tremendous amount, and I'm not going to go through the detail. I'm just going to draw out two bits. So we have got a particular focus on making sure that our disciplinaries are as prompt and supportive and robust processes as they can be. And as well as doing that, we also want to try and focus on avoiding the causes of disciplinaries in the first place, as well as helping managers to react really well and supportively when things go wrong. We've had some really good discussions with our people committee, Ned, on this. And I also think things like the resets that Ashling's doing and other directorates are doing as well in teams are really helping to get the culture right. And I think that will really help us make sure that people don't reach a breaking point where they step over the line in terms of disciplinaries. The second is about continuing focus on data about disabilities. So we know that people can understandably, I think, be really reluctant to share personal information about things like a disability, but we really want to help people understand how this helps us to make things better. So having really good data about race has helped us to be able to drive real tangible improvement. So the more we understand, the better we're able to work on it. So these two action plans focus on race and disability because they're the two areas that are asked to report on publicly, but they are, as you all know, part of a much wider action plan, our Building a Fairer Oxleas action plan, and that looks at all protected characteristics. And we're actually planning this year to look a bit at class as well. That's something that's come up from our discussions with staff about how that's treated. And we've got some big bits of work that go across all of those. One is a comms campaign to show that BAFO is a priority for all our senior leaders. Hopefully you'll have seen that on our screensavers, the talks that people have been putting on and on social media. And we're also asking all teams to get involved in a BAFO 5-step challenge with a view to them becoming BAFO accredited. And that's because we know that conversations around some of this stuff, around inclusion, around race, around sexuality, they can be difficult conversations to have. So we're trying to create a structure that makes it a bit easier for people to start having these conversations and get over that hump of discomfort. And it also helps us to work out where the pockets of disengagement are with BAFO so that we can work out which teams we need to go out to, reach out and support people more closely. So it is a really huge programme of work, and the programme BAFO goes from strength to strength every year. And, you know, I'm really grateful for the commitment that all of the exec and the board show on this agenda. And I think things are feeling as though they're starting to move. So that's what I was going to say. Thanks, Andy.
Thanks, Rachel. Nina, please.
Thanks, Andy. I just wanted to add one comment to what Rachel has said, which is there is clearly an enormous amount of work underway, interventions of different kinds, some shorter term, some longer term. The one thing I would like to call out is we have had a number of deep dives as People Committee non-execs with Rachel and her team, and we've had some really candid discussions about some things that are actually probably uncomfortable for a number of us. But the environment that they have created for us to be able to have, and I'm referencing Rachel and Kim and Debbie, the environment that they've created for us to be able to have those very direct, very candid conversations has played a massive part in giving us the assurance that we need as a committee to discharge the responsibilities that we have and to support them in the best possible way, I hope, as they continue to take this work forward.
Thank you, Nina. Jim, please.
Rachel, I think it's a very detailed, comprehensive plan. It's really well done. Just your comment about class. I mean, I thought that was dead. So it'd be really interesting to get your view on where's that come from and how does can that be embedded in the work that you're doing?
Yeah, I've just had a lot of people sending me texts and WhatsApps about this as well, so it's obviously come as a bit of a surprise. I've just been reflecting on lots of conversations that I've had actually going out and talking to teams, that it's something we don't discuss. Accent, education, background, all of those sorts of things. And I think there's a sense that these things do continue to play a part in what it feels like to be in an in crowd within an organisation. And it just felt that it was an interesting conversation to have. I don't have all the answers up my sleeve, but the strength of BAFO has always been if we listen and people tell us about where they encounter problems, then we can start to work out what the solutions might be. So it's a conversation we're just starting, Jim, rather than one to which I have an action plan to support it yet.
That's a really interesting point there. Anything from anybody else at all on that? If not, I mean, superb amount of work, really well done. You know, massive amount gone in, Rachel, from you and your team, and really, really well done. Okay, we'll move on to the next matter, please, which is now item 12, Risk Management Annual Report. Stephen, please. Stephen?
Sorry about that. It was such a good introduction I was making there. So I'll start again. The risk report is brought to the board annually. It comes through the executive first of all, and then through audit and risk. And it's useful perhaps to just, this is for noting, useful just for me to remind us all about some definitions. So a risk is basically something that has an adverse impact on an organisation's objectives. It introduces some uncertainty and it is outside our immediate control. When all the appropriate mitigations have been undertaken, what remains after that is called either a residual or a tolerated risk. And then if all the mitigations are successful and it's no longer deemed to be a risk, then it becomes a closed risk. So they're the three basic things that we need to bear in mind. What's a risk, what's a tolerated or residual risk, and what's a closed risk. On the report, I would just mention, I think, 3 other points. In terms of the number of risks that we hold on our BAF, that is very much within the sort of scale that our external auditors have advised us to work within. They normally say sort of 15, 16, 17 risks is reasonable for us to keep under control. Secondly, both at board and the committee, you'll see in the various analysis that Sue Owen has put together, there is quite a good movement about new risks coming on, risks being tolerated and taken off committee boards, committee risk profiles, and risks being closed and tolerated. So it does show that there's good movement and all the risks held, either the board or committee, are under review throughout the year, which is quite good. We can also see that there's been effective review from a move over to the directorate structure away from the borough structure, that has been reviewed through all the committees. And also Sue has included on page 13 of her report, 116 of the bundle, some examples of where the mitigations have introduced real good improvements in the way we operate our programs. And I always think that's important because I think for some people, risk can be seen in a kind of negative way, almost as if it's something we've just got to do. But in fact, risk is very much about identifying something that isn't working very well, could endanger outcomes for patients and the way the whole organisation works. And so the whole point about mitigations is to make us work better and give better outcomes to our patients. So I think it's very good to see it really culturally as a positive rather than a negative thing, which is why it's good that Sue's put those examples in. Happy to take any questions.
Thanks, Stephen. I think it's a really good point you make about the work that's being done on this to make the risks really relevant, and things do happen as a result of it rather than some separate enterprise to the organisation. So well done to you and to Joe and everyone else involved. Any questions for Stephen on this? If not, thanks very much, very comprehensive. And I repeat my thanks to Joe. I mean, she does a huge amount of work to get this right, so really well done. Thank you. Right, okay, if we now move on to the reports from the committees. PQAC first, please.
Thanks, Andy. Just a few things I wanted to mention this month. The first one was the IBR exception report, and it's clear to see that we have 16 key metrics that we haven't met. But just to give the board assurance about those, one that we've already discussed previously in Ian's report about all the things that the directorates are doing and the very detailed, comprehensive reports that they gave earlier. So we're talking about the reset programme that acute and crisis have done, and all the work that's due to come out of that, and the service redesigns in CYP, the RTT and psychological therapies work that's going on, adult community physical health, they're getting involved with the Involved programme. So there's a lot of work going on, which will then rectify all those metrics that we are just missing out on. Also, you'll see in the papers that we also include a detailed analysis of each of the metrics, just to give a bit more background on it. In addition, I wanted to talk about the deep dive in violence and aggression. We've talked extensively today about violence and aggression and all the work that's going on there. So we had a focus on it at PQAC, looked at all the data and had a discussion there, so that proved useful. And then we had a fantastic presentation from our COMAD service, and it's our mental health and drug and alcohol service, which looks to see our patients in a different light and other trauma-informed issues that they may have and other problems that they may have, and helping them to deal with this. And it was really inspirational to see that we don't just see our patients through one lens, but actually we see them as a complete person with other issues that we can assist in. And it's good that we have services like this within the trust. So that was really positive. And then to end our July meeting, we started in our AOB asking, with our governor involvement question, asking them at the end of the meeting, what would our staff and service users think of our discussions? And again, that was really positive as to the comments that they made back to us based on our discussions. And one of the key things that came out to me afterwards was that we need to learn to communicate, not to be heard, but to be understood. And that was the real strong message that came out to me. So I think going forward, that's what our committee will ensure that we do. So it's not about just telling people what we've done, but those people who are listening to us, that they truly understand what we've done and why we've done them. But that's all I was going to say, but happy to take questions. Thank you.
Thank you, Yemisi. I mean, obviously we've touched on some of those things in the report earlier on. I'm just wondering if there's anything else people want to raise. I don't want to go over this again. We've got the reassurance from the Quality Committee, but if there's any particular points that arise, I mean, for me, one of them was just looking at the complaints target on there and what's happening on that front. Neil, is that one of yours?
Thanks, Andy. It's a shared one. Got a new process for that because we're thinking about complaints both in terms of performance, i.e. looking at whether people are fulfilling the actions they said they would do, as well as quality. So performance, we've got a new process to monitor performance, to try and look at how we're completing both the outcomes, but also the timeliness of the response. That's and so Ian and I are working on that with Simon, and that's reporting up through PQAC. And then we're looking at our redesign to try and make the whole system more rational, which is more part of quality. So we've got two different ways of getting a handle on this, which I really very much welcome.
And yeah, I think to add to the point that you raised about the 30-day complaints, as we know, it's a perennial metric that we've constantly missed for years. So we've taken an innovative approach to think in a completely different and radical way of doing this. And we are now beginning to see some fruits from the radical approach that we are taking to actually go back to bases and try to pick apart what the actual issues are. So the fact that we have discovered that our staff are finding it increasingly difficult to do those complaints with the time limits that are given to them, the fact that they don't have protected time to do it, the fact that it's affecting their well-being to do it. Having now got those answers, we're now able to put mitigations in place and to ensure that when we move that metric, that it's a sustained movement and that we don't revert back to it. So there is progress happening on that front.
Yeah, thanks very much. Yeah, I was concerned about the amount of time our managers spend on this and the length of time that it takes. And I don't know. Well, no doubt we'll hear about it in due course. I wouldn't mind a little bit more next time we meet, just to see what the developments are on this, because clearly this is as I say, a big demand on our managers, but it's very important we get it right, isn't it? So anyway, right. Is there anything else for PQAC? If not, we'll move on, please, to continuous improvement and innovation, please, Suzanne.
Thank you, Andy. So just to note that we have changed the name of this committee from an abbreviation which used to be quick to now it's KICK, and I think perhaps KICK is a slightly better abbreviation. The key decision that we need from board today is just to approve our terms of reference going forward, because we have substantially altered the terms of reference. So I would like approval from the board on that. The main change in what the committee is doing is moving a little bit outside of the focus in the past on QI, quality improvement with a capital Q and a small I, into really understanding all of the improvement activity which takes place across the trust. And that's what we've tried to encapsulate in the terms of reference, which is to say that we're not abandoning quality improvement, but recognizing that there's an enormous amount of improvement activity that takes place under different rubrics, including responses to audit, or going back to the report that Aisling shared with us earlier, all of the sort of reset activity which is going on in that directorate. So people may have had an opportunity to look at the work plan. That work plan sets out how we're aiming to ensure that what we get at that committee is an opportunity to really hear about and showcase some of the excellent improvement work which is going on, and to celebrate that with people who have worked very hard. It's also to make sure that we align our quality improvement activity with the Trust's strategic goals. And that's what we've attempted to do with that work plan. The only thing which might not have been very clear to people is that we have a new item on our agenda, which is called the improvement focus. And broadly speaking, the improvement focus is a bit like the old show and tell, which people who used to attend the Quality Improvement Committee will remember. Those always used to be a show and tell about a quality improvement project that had been supported by the quality improvement team. The new idea of the improvement focus is to say that we really want to encourage our staff to think about improvement projects that they've undertaken, whether or not they were QI, to bring those to us, to have an opportunity to share them, to share some of the learning, to share some of the challenges that might have come about with doing that. So one of the messages that I'd like to use this opportunity to help spread is that we are on the lookout, particularly for projects which people want to share, which have been done by clinical teams. It may have been a really good audit. It may have been a reset, to use Aisling's terms. It may have been something else. But we really want to see people. We really want people to understand that the committee is a place that they can bring those projects to and celebrate them and use it as a way of spreading the learning.
Yeah, thanks, Suzanne. Any questions at all on that? We're going to look at the terms of reference. Does that go through audit at all, Stephen, in terms of reference of the subcommittees? And you're on mute again. You're on mute, Stephen.
Hi, Andy. Can I come in? The terms of reference have come to the board for approval, so it's at the right place for the board to approve.
Yeah, I do have some memory of audit having an oversight of some of these as well. Stephen, do you have any oversight of those?
Audit have an oversight on processes, certainly, but I think the same as Sally, that the terms of reference usually come straight to the board. Well, come to the committee first of all and then to the board. Okay, fine, thank you. My only observation, I suppose, was it's quite a lineup of membership, isn't it? And this is for a monthly meeting. It's there's a lot of people there. And whether
it's
it was
bi-monthly, Andy.
Is it? Oh, right. I thought I saw it every Wednesday, every month. Okay. Because it's just a lot of people, and
the actual membership's quite small, being the board members, but the wider attendance. But I guess that doesn't have to be at every meeting.
Just look at all the clinical directors, etc. Anyway, I'll leave it to you. Clearly, you have said in there that you'll take deputies. Sorry, it is bi-monthly, of course. If necessary. Anyway, are we in agreement with the terms of reference? Other committee members have read this and happy that there's no significant overlap with your committees? And if you're happy with that, then we approve. And nothing else for that, we'll move on to business then, please. Thanks, Suzanne.
I think I'm doing this, Andy, with Joe not being here today. Is that right?
Yeah, please.
So in terms of the, just a couple of points to bring to your attention. Obviously, we've already discussed about agency expenditures, 3% above the NHSI threshold, but I won't go into that anymore. I think the ICS figures are interesting as at month 3. Ezra may want to come on this, but certainly our figures are relatively good actually, but for the area, they're not looking so good. It does exclude additional savings that can be brought into the equation. But I think by the end of the year, the ICS final figures will not be quite so flattering. Ezra will want to comment. The Kent Pharmacy bid and Surrey Prisons, I know we're going to come to in part 2, but both of those were dealt with at a scheduled meeting and the bids were approved. And finally, on the cost improvement programs, but basically the committee was very pleased with the progress that had been made. And when you look at the programs that are now rated as red, they're in fact a relatively small proportion of the total proposed savings. So that was quite impressive, we thought. Astra, anything you want to add?
So I suppose just really talking about the ICS month 4 figures, we're literally the only organisation in surplus. The ICB as a whole, just the central team in terms of the commissioning element, the old CCG element is break even. Everywhere else is in deficit. The non-recurrent that Steve Dilworth was talking about there, that is the balance sheet flex that they said they would be able to play into the programmes. Now, there was quite a lot of that listed within the acute sector. None of that is so far actually being put through any of their figures, apart from the figures for Lewisham and Greenwich. So what they've said is they were expecting that to be phased in later on in the year, but most other ICBs have now started to play that flex through. We already have a degree of that worked out within our SIP plan, so we have been playing that through. At this point in time, for these figures, there was about 500,000 that had been played through from the balance sheet over and above what we had within the SIP position, and that has all flowed through as a surplus and then had gone through as a forecast. We will be doing, everybody in the ICB is due to be doing a forecast based on month 5 that will then be firmed up in month 6, and that will come through the business committee in due course. So I was going to add, thank you, Steve.
Well done, thank you very much. Happy to take questions. Yemisi, I think.
Thanks. I've already had a quick discussion with Steve about this, but I think for the purposes of the minutes, on page 157, it does talk about Bridges Healthcare, and the trust has agreed to write off this debt with final approval needed from the board of directors. So I just wanted to confirm that we didn't require a formal decision from the board for this, and it was okay for the business committee to take that decision.
That's correct. That was an oversight. Apologies for the fact that that got into the meeting. Usually what it is that's taken to the Audit and Risk Committee, just in terms of overarching debt, but it was actually approved by the Business Committee en route to that other committee.
Thank you.
Right, so it's not, we're not required to make an approval here. Is that correct?
No, I think it was just to make sure that you had oversight of the fact that that's what the Business Committee outcome was.
Okay, fine. Right, so that's the final end of this then, is it, on Bridges Healthcare?
Yes, I think we've had many discussions on it. I don't know if we want further discussions on it. I'm inclined to say that should come within part 2, Andy.
Yeah.
But it might not be a bad idea to have that kind of summary within part 2 very briefly, if that works for you.
Okay, I just want to thank you, Stephen, for your pursuit and tenacity of this issue, but and we can discuss it a bit later on. Anything else on Business Committee? If not, then Partnership Committee, please. Who's going to speak on this with Joe not with us?
Oh.
Steve, were you going to offer or should I go?
I'm very happy if you go, actually.
Yeah. Well, yeah, it is a brief report, as colleagues would have seen. Not a great deal to say. We went through our partnerships right from the ICS base, which Ian helpfully talked us through. The only thing that I was going to mention is how we ensure that as we articulate the risk, you know that we currently don't have a risk on the path, but if we are going to, that we take account of what risks the ICS has got. And it does stay there, and sadly, I'm not sure if this is right or wrong, that we'll be having a further discussion about risks next month. But I fear that the agenda at the board, the strategic board, is now pretty solid. So I'm not sure if it's going to come in October or whether it's going to come later this year. I'm happy to take any questions. I don't think there's anything contentious in that brief summary.
No. Any questions on partnership from anyone? If not, thanks very much. We'll move on to infrastructure, please, Jim.
Thanks, Andy. We had a cut-down meeting this time round because a number of people are on leave, so it'll be quite brief. And a number of papers you've seen already. So we had Building Block 7 update, and we also had the update on the Blean Grove proposal and the data governance and risk paper. Interesting enough, we did have an update from Alison on the informatics, and that's where we discussed the two IT issues that happened to other trusts. So we went through the two incidents and understood as to whether they would be affecting us or could affect us. And Alison gave us some assurance that we are in the clear on both types of incident, although we may need to do more work on our tier 1 supplier compliance. And that's going to come back through infrastructure. And then we had a quick discussion at the end. Steve saw some interesting data on concrete in a certain time period and some issues with the concrete failing. We had a review, and the good news is we don't have any of that concrete on our estate. So that came through as well. And that's it, really.
Thanks very much indeed, Jim. Any questions for Jim on that? If not, we'll move on to People Committee, please.
Thanks, Andy. I won't cover what we have already covered at length in the meeting so far from the People Committee's meeting in July. There are 3 areas that I would like to very briefly touch on. The first was a workforce planning report that we received from Morehouse, which I asked Rachel to circulate to all board members. So I hope you've had a chance to skim through it. For me, it was one of the richest and most insightful pieces of analysis that I've seen in a really long time, but also incredibly sobering as to the scale of the workforce challenges that we face. So most of our directorates were flashing red. Acute and crisis, community mental health, CAMS and prisons, and all of the challenges that were outlined are going to be taken forward through a combination of either central initiatives, so things like employer offer and external branding, and others which are more local interventions. People Committee is also going to be asking individual directorates who already come to us on a rotating basis to outline what their specific workforce plans are, because we want to be able to, as much as we try to support and challenge our people directorate, we want to be able to do the same with the individual directorates, recognising that there are some interventions that need to be directorate specific based on the individual challenges. We also spent a lot of time talking about cost of living proposals. As we've been in the meeting, the PM appears to have issued a price freeze of £2,500 for the average household, which I think is welcome, but it is significantly in excess of what people would have been paying just a few months ago. So we heard at the committee about the range of existing measures that are in place, and we also heard about the new proposals, all of which are outlined in the paper in your pack. And I just want to commend Rachel and her team for the amount of thought that's gone into this over quite a long period of time. they have sought to address in as many ways as possible, including using social impact initiatives like WadeStream, which we had a presentation on, which was fascinating, to be able to offer support to staff in as many ways as we possibly can, and that are tailored to the ways in which people actually need support. We also reviewed the nursing strategy for 22 to 25. So that's a 3-year strategy that focuses on the priorities that are outlined in the paper, and it addresses everything from recruitment and retention to well-being to international recruitment. And what I want to highlight is Jane's team and the corporate nursing team are a really small team, and I want to try and make sure that we can give them as much support as we can going forward, because it will be all too easy to focus on the immediate pressing challenges that we face over the months ahead, but we really need to invest in this strategy for the longer term if we want to try and address some of the root causes in a more sustainable way. So there's a lot of sensible thought that's gone into that piece of work. And then finally, we heard from the chair of our BAME staff network, which was a very positive and uplifting discussion, as they always are. So happy to take questions.
Well done, Nina. Thank you. Questions, please, for Nina or Rachel on that. No, really good, very, very comprehensive, very reassuring to see that, it's a massive issue. All of these are big issues, but really well done to everybody for that work that's gone into that. So if no further questions, we'll move on. A nursing strategy. Is that going to come up now?
Internal audit. Sorry, audit and risk next, isn't it?
Yeah. Okay. Was there nothing? I mean, did you captured everything in that, Nina?
I did. I wasn't aware that nursing strategy was going to be looked at specifically. I tried to draw it out in my. It's not. I can see if you shake. Jane, did you want to come in on this?
Yeah, I think we have covered it at the People Committee. I understand that the GOSTI version will be circulated to board members. They're just waiting for some more photographs to make it fully inclusive of all our nursing professions, and then we'll circulate it. So thank you.
All right. Okay. Thanks very much for that. We'll move on then to audit and risk, please, Stephen.
Yeah, thank you, Andy. 2 internal audit reports, one on the job planning process, which is partial assurance with improvements required, which is a little bit below the median that we would normally expect. 2 high-level recommendations, one about the lack of a proper planning policy, and secondly about formal timelines for completing job plans. But we've got a good schedule to correct those. The timelines will be dealt with by the end of October, and the policy, which needs a little bit more work on it, by the end of December. The other audit report was about fit and proper persons. This got significant assurance with minor improvements, which is a very good outcome, with a comment that we had a very strong compliance within the policy, 1 medium and 3 low scale recommendations, all to be completed during this month. So that's going to be dealt with pretty quickly. We had a presentation from Jim and the Infrastructure Committee on risks for that committee. I was reflecting actually afterwards, Jim, that when you think about the changes that infrastructure have got going forward, about digital enhancements, carbon zero impact on the estate, changes to the capital regime, probably infrastructure has got the biggest changes of any committee coming up over the next couple of years. So Jim, good luck on that one. And then thirdly, on legal services, just to mention, again, great work from Sue Owen, who of course handles all our risk profiles, but also does a report on a very comprehensive report on legal services. And the one thing that struck me, I did mention this at the pre-meet before, was just about the increase in prison claims. So when you go back a year, mental health and community would have had 34% of our claims, prisons 24%. But now, as at the last report, July 22, prisons are by far the highest incident of claims. They are 37% of all our claims. So that's quite an interesting, I think, development. And just one for us to, I can't actually quote figures on the cost, because as you'll appreciate that with live claims going through, we don't know what the cost on that is. It's usually only sort of 12 to 18 months before we can put hard figures on that. But certainly one for us to keep an eye on. And I know it has been raised certainly at Audit and Risk and Business Committee before in assessing prison tenders. That is one of the items that we do consider, things like this about any additional legal costs. Azra.
I was just going to come in on that because we're looking at the paper in terms of the corporate increases in relation to the prison's expansion. We've done a piece of work on this, and although there's quite a high volume of claims, they tend to be fairly low value claims. So how that feeds through into the NHSLA premiums, we don't think it's a major factor, because the really high volume claims, which would be the ones that would result in major increases to our premiums, usually come via mental health.
Yeah, very fair point. So Ezra's quite right. I mean, if it turns out that a lot of these claims are someone has just tripped over a pavement somewhere, that won't be worrying us too much. The thing will be around clinical negligence, I would suggest. So that's where we need to, which will be the high level of monetary value. Yeah, but yeah, good point. We'll probably be able to assess that a little bit more over the coming year. That's all from me, Andy. Sorry. Happy to take questions.
Yeah, thanks very much, Stephen. I was just thinking about the legal claims and whether we've got any feedback loop from those claims back into any practice issues. Because sometimes there's such a delay, is there not, between us paying out on something and whether or not there's anything that should feed back into our practice. I know in other organisations I've been involved with, you end up paying out huge amounts of money and no one from the operational side is necessarily that aware of what's actually happened. And I wonder if that crops up at all when we're discussing those matters.
Yes, Sue will want to come in here, but probably about 18 months ago, we did introduce a system where Sue would notice, as soon as she was aware of a particular figure on a claim, then she would bring that to our attention. I'm just trying to remember what the figure is. It's something like 250 or 300,000. Is Sue on the call today? She's not on board.
No,
Oh, you are.
Yeah. Yes, Steve. Yes, the figure we agreed was 300,000, and they're brought to the attention usually via the Tuesday morning risk group in the first instance, and then reported to Audit and Risk. But as part of the ongoing process, directors are always involved in claims. We notify the clinical team and the service director when a new claim is received, and learning points are generally kind of fed back as part of the ongoing process if they haven't already been addressed as part of an SI or complaint, which in the majority of our incidents, any learning has already occurred through other processes, and the claim actually follows on from a complaint, an SI or an inquest for the vast majority of our claims.
Yeah, that's helpful. So helpful very much, Susan, and Sally's just added something on that. Was there anything else for anyone else on audit and risk? If not, it was remiss to me, Susan, on item 12 and for this item, and to thank you personally for the huge amount you put into it. There's a very, very comprehensive approach I think we've got here, and much of that is due to the energy and effort and imagination that you put into it to get this as right as we possibly can. So, Susan, thank you very, very much indeed for everything you do on that. Health and safety now, please, Nina.
Thanks, Andy. A quick one on this. We have heard a lot already about violence and aggression, and Health and Safety Oversight Committee received our presentation on this work as well. We spent quite a lot of time discussing the annual report, and we will be receiving a presentation on iAuditor that's kind of the engine room that supports the results that are produced through the annual report. We had and spent a lot of time discussing an update report on the work that's underway to ensure full compliance with Kitchen Sharp's policy. Two things to say on this. There, at the time of our meeting, which was in the middle of July, there was still action required in quite a number of areas to take forward some of the key points coming out of the risk assessments. So we expressed a real urgency to making sure that these happened. And secondly, there was a very useful discussion around whether the policy really has been made future-proof. So there was a sense that it hasn't necessarily kept pace with some of the practicalities of structuring services so that we meet rehab needs of patients. And so a review of this policy is underway, and we very much welcome that. And I think those are the key points that I would outline. Happy to take any questions.
Just on the Sharps policy, has that been renewed or reviewed about whether or not it's still the right policy in the right places? Particularly, I was thinking about rehab across the trust.
That's exactly the exercise that's underway. Ian and Rachel can comment on the detail, but at a high level, yes, that's exactly the work that's underway.
Okay, no, I don't necessarily want to go into that, but thanks for that. I just want to make sure on my various visits, some people have come back to me and said, it is about time we had a look at this, particularly with regard to moving people on from our organisation back into society and things such as that. Particularly those who are allowed out for daily visits anyway. But anyway, I'm just reassured that's being done. Okay. Yeah. Is there anything else on health and safety? If not, thanks ever so much. Well, if we go on now onto our board visits, usual rules apply. You can be reassured that people have read your report. So it's really a matter of highlighting anything you wish to bring to the attention of the board. And there's one there on Bexley community. Joe's not with us today. Iffy, anything you want to highlight from that meeting?
Yeah, just a few things. Great visit. And I think what Joe and I found really striking was getting a better understanding of the sources of referral and the role that they've been playing with respect to discharges from the acute trust. So that relates to the earlier conversation we had and how they work really hard to manage their waiting times and to prioritize those who've been discharged. You will see there that there is some concerns about travel costs, which I'm pleased to say that the work that Rachel and her team have done and shared with the committee with the support of the exec has to some degree addressed that.
Yeah, that looks good. I don't want to go into the pool card debate right now, but it'll be interesting to have an update at some stage or other, and also the risks that might be associated, as well as the benefits that might be associated with some of these schemes that we're coming up with, because this is a perennial from many of these visits that we do at the moment, isn't it? Nina, please.
Just a couple of points to pull out, Andy. Abby and I did some brilliant visits actually to Birchwood and Danson back in June. And the 2 points that I wanted to draw out were when we went to Birchwood, the lady who showed us around was the clinical team lead, and she had joined Oxleas in 2002 as a band 5. And at the time, she told us that when she started, her senior nurse told her, don't aspire to higher because your limit is going to be band 5. And that for me just demonstrates the scale. We won't be the only trust at which those comments have been made. I dare say there are very similar issues in a number of other trusts across London and the country. But that for me illustrated the scale of the work that and the need for the work that that is underway with BAFO. I was really quite, I was really quite taken aback by it. The second was at Danson. We had the fortune of being able to speak to some of the band 2s, and the 2 that we spoke to were actually had joined us from very different industries. One was from the financial ombudsman, and one had changed tack and moved to us. I think his background was in engineering in Germany, and he wanted a fresh start. So for me, and they were both deeply impressive, and band 2. So for me, it illustrated just how much talent we can tap into out there. And I think for the work that we're doing on employer offer and rebrand will be hugely successful, I think, in helping us move forward, because the supply or the drive to join the NHS is still very much out there.
Yeah, it sounds like very good visits, Nina. Thanks ever so much for that. Stephen, please. Is it Greenwich Community?
Oh, yeah, sorry. I hadn't realised it was up to me already. Yeah, thanks. A very good, positive visit. I mean, the kind of running themes that we so often come across, you know, strong team spirit. Nice to see such loyalty to the organisation. Many of the staff have been there a long while, and comments that how they thought Oxleas was a very good employer. There were the maintenance issues that have already cropped up elsewhere on other visits, you know, around car parking, cost of petrol. They particularly mentioned, and it's got in, and it is covered in our issues raised, about delays in recruitment. But I know Rachel will want to come in here. There are reasons behind that. And they were especially mentioning about they would have liked to there to be a contact number within our HR that they could chase up what's happening on applications, etc., and the recruitment process. As I say, Rachel, perhaps I know you came back to me on this. Any comments you'd like to make?
Yeah, so clearly there's a huge volume of recruitment going on at the moment, and the system that we use, the track system, enables you to track directly what's happening in relation to processes, and we're trying to get people used to using that rather than always picking up the phone to try and get guidance. But we are making sure that at the bottom of every email there is a contact detail for someone in the recruitment team. So if people do really need to speak to someone, rather than being able to do it on the system, they've got someone they can speak to, and that's in direct response to that feedback, Steve.
Yeah, thank you. Thanks a lot for that, and that's all being fed back to the team. I always do mention about the access to the charitable funds on all the board visits that we make, and I'm pleased to see there is actually one going through for this group. So that's at least a successful application progressing. That's it, really.
Thanks, Stephen. Any questions at all for Stephen on that? If not, we'll move on to Yemisi, please. Acute and crisis.
Thanks, Andy. So myself and Azra had a really good visit to Woodlands, and very detailed. We saw 5 different teams, wards, and was able to spend time with them. And it was a great visit. You could tell people were really invested in the work that they were doing. They were really proud of the work that they were doing, the teams that they worked in. There's a sense of camaraderie. I think my overall impression, it was a very timely visit there. Obviously, people worried about the cost of living and staffing issues. So to be able to offload that to us, I thought was really important. And luckily, Azra was there and was able to offer them some good news. So that went down incredibly well. But I really happy with the visit. Yes, you can see from the reports that there are areas that people raise with us, but that, again, they're mainly around vacancies and estates well-being issues that have now been passed to the relevant, assigned to the relevant people to look at. But yes, well enjoyed. Thanks.
That was some really good visits there. Really well done. Thank you. Stephen, please.
I think we have to congratulate Yemisi and Azra for producing the most comprehensive board visit report I've ever seen.
It was really good. It's there's a lot to see there, isn't there? You know, not only the wards, but the ECT and the HTT. There's an awful lot of issues there, but they are hardy perennials, aren't they? That keep cropping up sometimes, particularly around the travel and mileage and the relationships. HTT, you know, home treatment. I mean, the community mental health team. So you caught a lot of things there. So really well done. Thanks ever so much for that. I don't think there's any more for those to come. So we move on to the Council of Governors update. You've got it there in front of you. Sue, did you want to add anything at all?
The thing I would say is, following a discussion between myself and Anne-Marie yesterday and Joe, the planned Governor's Away Day will now be virtual because we've had such a poor response, and we didn't want to, I don't want to say waste money, but we didn't want to spend money inappropriately. So we decided to go for virtual, and we're arranging the Governor's Away Day for virtual rather than in a place, because otherwise it seemed a lot of money to be spent with not the number of people we were hoping would come. So it's a question for me and others to chase up some of the governors to be more involved, if you like, next year. I should be putting the whip out. Figuratively, not actually.
No, I think it's interesting, isn't it, Sue, how, you know, obviously COVID has such an impact, has it, in every way, and affected the way people's willingness to travel. But it would be good, all being well, for us to start getting governors back out again on the face-to-face visits as well that we discussed in the pre-meet. Well, thanks. Sally, please.
Just a quick one to say, just highlight the membership committee being involved in talking about the annual members meeting, which we are looking to have as a face-to-face meeting, and the date for that of the 13th of October. So really looking forward to a reconnection with everybody there.
Just a reminder where it's at, please, Sally.
We've booked Woolwich Works, which is in the centre of Woolwich, so in part of our patch.
Oh, good. And so that should be pretty good for people to get to by public transport or whatever. Excellent, thank you. Well, thanks, Rex, and thanks very much to the governors who give us so much support, and we're looking forward to more. Forthcoming agenda, please, Sally.
So this is for the board to note and raise any other items that they think will need to come through to me if you'd like to contact me outside of the meeting. But this highlights the rolling programme for the board.
Okay, anybody, any observations on that? If not, we'll move on to any other business from anyone at all. I don't see anything raised. Review of the effectiveness of the meeting. I won't hear any comments about the length. I think, as I said earlier, I think there was I personally think there was a really good, you know, some really great discussions there on some vital issues. And you know, and I really do want to thank the exec for the huge amount of energy and effort goes throughout the month, but in presenting these papers to us, I thought were extremely good. And to my colleague Neds for the interest that you have in everything that happens within the trust. If there's nothing else from anyone else on that, we'll bring part one to a close. I don't think we have a separate link, do we, Sally, for part two?
No, that's right.
So for whoever is not normally part of part two, we can say goodbye to, and then we can stop our broadcasting, Steve, whenever you're ready. That'll be great.